Again, for those that are just joined us, so
It's preparing to stream. It's
we'll be streaming in just a minute.
on mine. It says we're live streaming.
Well, again, good morning, everyone. I apologize for the delays and getting started, but it's good to see everyone. And
Start to hear, Mike.
good morning, everyone. It's good to see everyone. Again, I apologize for the delay. We had a couple technical issues that we had to work through, but we are now live streaming. And I want to, again, thank everyone for taking time out of their busy schedules to be part of our discussion today. We have a lot of important work to do, including going over the budget for the next biennium and reviewing the activities of the last month and the implementation of the various programs of the consortium. So with that, why don't we go ahead and take the official roll call, and then we'll get started.
Dr. Lakey.
Here.
Dr. Goodman.
I am here.
Dr. Williams.
I am here too.
Dr. Liberzon.
Here.
Dr. Harper. Dr. Wakefield.
Here.
Dr. Mitchell.
Here.
Dr. Thompson. Dr. Martin.
Here.
Dr. Podewells. Dr. Farmer.
Here.
Dr. Nemiroff. Dr. Newport. Dr. Ton. Dr. Robert. Dr. Wagner.
Here.
Dr. Vo.
Here.
Dr. Suarez. Not that I saw him, maybe not. Dr. Bobato.
Here.
Dr. Pliska. Dr. Blader.
Here.
Dr. Chapa. Michael Petriarca.
Here.
Brittany Nichols.
Here.
Dr. Taminga. Dr. Ibrahim.
Here.
Scott Schlacklin. Sonia Gaines.
Here.
Elizabeth Mayer. Dr. Martinez.
Here.
Dr. Keller.
Luann, this is Monica Tyson. I'm representing Andy today.
Danette Castle.
Here.
Danielle Wesley. Dr. Wesley.
Here.
Okay. That's it. Thank you.
And Luann, how many people do we have?
We have 1, 2, 3, 19.
We have 19 people. And thanks, Monica, for being here. I can't, though, count you as a part of the executive committee for the quorum. And so we are at 19. So again, we're barely over the quorum, and would again encourage people to let us know before you leave. We have to maintain at our number. There'll be a couple of people that I know that are going to be coming in a little bit later. And so we should be in better stead at that time. Brittany, it looked like you were going to say something.
Yes, I don't think y'all called Dr. Johnson. She is our other representative now, replacing Dr. Bryant.
Okay, very good.
She was
Yeah.
called.
Okay. So Dr. Johnson, welcome. Good to have you here as in your first meeting. Thank you for being here.
Thank you all.
Very good. Any other announcements before we begin? So that puts us at 20. So we have a little bit additional room. So why don't we again go ahead and get started. First item of business before we can go into the budget and the programs is to approve the minutes from the last meeting. You should have that that was sent out to everyone. If you take a time to take a look at it, and after you feel comfortable, if there's a member that can make a motion to approve, we can go ahead and approve it. And I have a motion by Dr. Wagner.
Second.
Second for Dr. Vo. Any further discussion? Hearing none, all in favor of approving the minutes from the last meeting, signify by saying aye.
Aye.
Opposed, nay. Anybody abstain? It is approved. Next, we will go into the activities of the various activities of the consortium. We're going to start off with an update on communications and outreach from UT Austin. Melanie, I think I saw you just a little bit ago. Ms. Seswine, give an update?
Hi, I'm here. Can you guys
Great.
hear me?
We can, yes.
Okay. I'm going to try to share my screen. Let's see. Can you see the PowerPoint? Yeah. Okay.
Yes, we can.
Great. Okay. So thank you for having me here today. We're excited to share our update with you. First, I just wanted to kind of ground us in a timeline. We are starting our year 2 with this project. And in the first year over here, we really worked to do our research, be responsive, create the video, create some branded materials, provide support to the HRIs, create a social and digital campaign. And in year 2, we are continuing those same endeavors, and we are working to leverage the strategy and wisdom that we gained from the first year. Still offering the HRI support. We go to the coordinators meetings and the leadership meetings, and we get individual requests from the HRIs about some specific outreach, and are helpful with them. We are also going to be distributing the video in different distribution channels this year, and I can go over that in just a little bit. Let's see. So again, the branded materials and the collateral that we have created, a list is over there on the side as well. One of the things that we're just completing right now is that we, when we create a material or update a material, we are now have all of the logos for each of the HRIs. So we are able to individualize each of the materials for the HRIs. And there's a folder that we use together in teams so that they can have the updated materials that show the look and feel for a state effort, and also the individuality for each of their regions. I wanted to just do a little bit of analysis for the social media. We started really in March of this year in earnest with adding to what the Kosh team is doing with social media. We have a cumulative reach of 12,047, and the growth is something I want to point out as the program has expanded and has more time. Facebook grew by 26.8%, Instagram by 16.9%, and LinkedIn by 141%. And LinkedIn is really where we get to position CPAN's thought leadership with longer posts about whatever topic we're emphasizing. Digital analysis, we started the digital outreach August 1st, and I'm very excited to show some of these results. So for the digital outreach, we do Facebook. We also have banners, and the video is now being fed on some of these platforms. I want to point you to this website year over year chart, if you can see that. I hope it's big enough. This yellow line here is where the website performed last year at this time in July and August. And you see this year, it makes sense in July that there's more than there was last year. We have more activities going on and more people have heard about the consortium and CPAN. Right here, where we get a very large bump, is when the digital campaign started. And we can see a very large increase for the remainder of the month of August as this campaign is running. So you can see 153% increase from July in website traffic, 112% increase in sessions. And over here, we have the different channels that are driving to the website. So there's organic search, display, and direct. So we are excited that we can see the results of this so quickly right on the website use. And then the video. So we completed the video. We have one 3-minute video, and then we did 5 key message videos that go back to the research that we conducted for the motivating factors for clinicians. And that is, we have a very quick general overview, and then one about the referrals. That's actually a 15-second video, so it can be used in the digital campaign. We talk about the fact that this is no cost and you can probably bill for your services. We add information about the discomfort in your domain, trying to make people feel more comfortable. And you can see that in some of the advertisements that we have here, where it says, feel confident providing mental health care. So we're working on that key message. And the collaboration and time sensitivity. So we are working with the CPN leadership on the distribution and the calendar of when that's going to be coming out. And I will share that with the CPN coordinators, and we'll also share that with Dr. Williams to share in the CPN leadership when we are finished developing it. That's my update. Any Q&A that I can provide, any answers?
Very good, Melanie. Thank you very much. Are there any questions from the group?
Not a question, just a comment. The materials look spectacular, really impressive materials.
Thank you. I wanted to put some of those statistics because the team here at the Center for Health Communication works really hard on getting those materials done. And we have a great process to get input from the providers and from the leadership. So I'm happy that it looks that way to you, Sonia. Thank you.
Any other questions? Hearing none, Melanie, again, I really appreciate your work. And as Sonia noted, it looks great. And so really appreciate the work to expand the visibility of our program. So thank you very much.
Thank you.
Before I go to the next item, I want to make sure the record shows that Dr. Nimroff is here. Are there any other executive committee members that have arrived virtually since we took roll? Dr. Chapa, I see you have joined us. Okay. And Dr. Liberzon, you have joined us. Anybody else? All right. Hearing none, let's go to the next item, which is with Dr. Molly Lopez from UT Austin on program evaluation and our internal evaluation. Dr. Lopez?
Good morning, everyone. Thank you so much. Can you hear me?
We can. Yep.
Okay, great. Thank you. So we are working diligently to finish up the last fiscal year and get started on the next fiscal year. And really want to thank everyone for their help in terms of really examining the data to make sure we have good quality data. We know your teams have been really working hard to do some of that work to really make sure the data is reflecting the work that you're doing. I do have a couple of discussion items that I want to bring to you all today. So the next slide, please. The first one I mentioned a little bit last month, and that is we've been having discussions about an evaluation measure that can be used to really talk to the outcomes of TCHAT. We do have, of course, a number of important metrics, but one of the metrics that we are discussing adding to our evaluation of TCHAT is to try and gather a broadband measure that families can complete that will help us speak to really the outcomes of care at a family level. So some of the things that have been considerations in this discussion has been making sure that that measure will measure one or more key constructs that are important to the teams and that we feel are really a part of the outcomes and indicators of the value of TCHAT. We want to make sure that that measure is psychometrically sound, of course, and that it's been tested in populations that are similar to the populations that are served. We want to make sure it's sensitive to change and that it's low burden on families. And if possible, of course, sort of additional supports would be if it's low cost or free, as well as already being built in trait. So those were some of the things that we entered the discussion thinking about. Next slide, please. So what we have done to sort of make this decision is we did a review of global symptom and functioning scales, reviewed the literature, some other comprehensive reviews of those scales. And we also reviewed the existing team measures that they are collecting or planning to collect in the near future. Out of that, we made some recommendations and discussion among the TChat teams and the leadership, and had some really great conversations about the values of different measures and what folks felt might best fit within the workflow of their teams. And out of that work, we wanted to bring to you all a recommendation. And the recommendation is that all teams across TChat collect the Columbia Impairment Scale. And the Columbia Impairment Scale was chosen as a recommendation because it is a measure of functioning. And that was an area that most teams felt like they were not currently gathering information from families. And so there was not a duplication of the existing efforts for measurement-based care. I'm going to talk a little bit more about the Columbia Impairment Scale in just a second, but really that was one of the key factors, I think, in this recommendation, is that we were not providing additional burden to families by asking questions that were already gathered in other measures that folks were doing. The recommendation is that we gather that information from the caregiver, but there is, of course, also the opportunity, if teams would like, to gather that information from young people and or school staff as well. If you don't mind moving to the next slide. So a little bit about the Columbia Impairment Scale, and there is a copy of the measure in your materials that were shared with you. It is 13 items, so it does meet our criteria for being low burden and brief. It measures general impairment, including impairment with families, with peers and other adults, academic or occupational functioning, as well as the use of leisure time. It is psychometrically been shown to be a unidimensional measure of functioning, with a optimal cutoff score of 15 or greater, suggesting clinically significant functional impairment. It has been used in a number of studies. It is a part of the NIMH Phoenix Toolkit and has some really nice psychometrics behind it. So I think I'm going to pause there on that and allow for any questions or any discussions. And I'm not sure, but I think we probably need a motion to the recommendation.
Okay. Thanks, Molly. Any discussion about using the Columbia Impairment Scale? Any experience with the group?
This is Joe. I've used this measure actually in a follow-up study of child psychiatric inpatients and in 2 clinical trials, so I think it's an excellent choice.
Just
Okay.
a question, is it translated to Spanish?
Yes, it is.
Thank you.
Molly, can I ask a quick question? Is this measure best used for people with significant illness or early in the course when there is some initial impairment?
I would say that we have used it, personally, we've used it both ways, but I think if more of the research has been done with significant impairment.
Because I think this idea of how best to begin to understand functional impairment and early in the course, even before there's a significant quote unquote diagnosis or kind of fear, where we should be intervening for these conditions, is a big issue. That's what I was asking. So thanks for your
I think it was developed for epidemiological purposes. Hector Bird's studies of I think both in Puerto Rico and in New York City as well. In that epidemiologic context, I think it's proven to be fairly broad-based and not, you're not going to get ceiling. You shouldn't get ceiling or floor effects on that account, Madhukar.
Yeah, and the floor part is, so thanks, Jules, that helps.
Dr.
Dr.
Mitchell's trying to break in. Yes.
I have two questions. My first question is, will you tell me one more time about the age range of appropriate use for the measure?
5 to 18.
Great. My other question is, when I was looking at it, it reminded me a lot of the pediatric symptom checklist that I know is used in some groups. Was that considered? And if so, how does this compare to that measure?
Yes, that was definitely considered as well, and it was one of the strong contenders. The group felt like there was more overlap between the pediatric symptom checklist and some of the other tools that they were using. And so they felt like this was a little bit less overlap with some of the symptomatological tools. There is more work being done by the group to try to come to consensus around some of the tools that will be used for depression, for anxiety, for ADHD, et cetera. And so the thought was that this may have less overlap.
But overall, I'm so glad you're doing this, because we all so many times focus on symptoms and disorder and diagnosis, and our patients and families are more interested in what is the impact, what is it doing. So this is thanks for doing it.
Any further discussion or comments? Seeing none, is there a motion to approve the Columbia Impairment Scale as a measure for TCHAT?
So moved, Podewilz.
Thank you, Dr. Podewitz. Do I have a second? I have a second from Dr. Nimroff. Any further discussion? Hearing none, all in favor, signify by saying aye.
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 Those opposed, nay. Did anyone abstain? Hearing none, it is approved. Dr. Lopez, I'll turn it back over to you.
Thank you. Next slide, I have one more thing for discussion. One of the things that teams have been working very diligently on is examining all of the school campuses that TEA has identified as either charter or public school campuses. And we have been identifying who those key campuses are that we will recruit for the statewide expansion. One of the things that has come up as a part of that exploration is really understanding if there are any campuses that maybe should not be our primary focus for expansion, not that they would not be potentially eligible for TCHAT, but maybe not included in our overall denominator about all school campuses being enrolled in TCHAT. And so I wanted to bring to the group some of the discussion that we've been having, some of our initial recommendations, and get some thoughts on whether there's agreement with these. So again, to be clear, all school campuses within the public school system would be eligible, but there may be some for whom TCHAT is maybe not a logical fit, because those school campuses are specialty campuses that have available specialized mental health care on their campus setting. So that is kind of the overall rationale that we used when making this consideration, was whether or not there would be expected to be access to specialized mental health care as a part of those campuses. So I thought I'd run through some of those locations and what our initial recommendations were, and then open that up for discussion. So the first locations were adult prison and adult education settings. And the understanding is, because these will serve adults and not children, that they would not be included in the overall denominator. The next location is locked juvenile facilities. These are TJJD facilities that have school campuses within their setting. The thought was that these would not be considered in the denominator, because there will be mental health care access. Next would be school settings housed within psychiatric hospitals. Again, the recommendation would be that they would not be included in our overall denominator. And then similarly, generalized physical hospitals, medical hospitals as well that have schools on site. And then the last location in that column would be schools that are housed within residential treatment facilities. On the other side of our chart would be some specialty campuses that are recommended to be included because the expectation is they would not have access to specialized mental care. The first is early childhood or Head Start programs. Next would be specialized schools that focus on a particular population, such as adolescents who are pregnant, schools that focus on settings that are shelter settings for family violence, as well as shelters for foster care. The next in that column would be recovery high schools. And then university-based residential programs as well. And then last would be schools that identify as homebound to work with students who need to be in their home settings. So those are sort of the initial recommendations that we wanted to put through the group. And then I want to open it up for any questions or discussion. Dr. Wakefield? Oh, sorry.
Good. Dr. Wakefield, I see your hand.
Molly, can you talk more about what a university residential program is?
Yes, there are some universities that house programs usually for juniors and seniors that are on campus that allow students to get both university and high school credits as a part of their participation. They're usually gifted and talented programs. My exploration of them, they do have counselors in those settings that are targeted to those programs. So we were really thinking about whether or not there would be the feasibility of referrals from those campuses to TChat.
Dr. Blader?
I'm just wondering how this proposal comports with TChat's emphasis on shorter term triage, getting treatment underway, some intervention, but then within relatively, well, in the broad scheme of things, relatively short order, arranging for continuing care somewhere else in the community. It becomes a little bit of a concern when you're selecting, populations that are possibly have rather intense long-term needs. Are we saying that something is better than nothing, or I'm just wondering how many of these sites really should be trying to engage with a specialty mental health that's local to them and forming that kind of partnership rather than using TChat as the primary vehicle for that.
If I may, Molly, I think that's what she has done. And the column on the left would be entities that would need more of that long-term and have mental health support for a variety of other reasons. And as we do our statewide rollout, wouldn't necessarily be the top priority for us since they already have those type of supports. And the column on the right is more of that where a child would need that short-term support and then hand off. Molly, do you have anything else to add to that?
No, I think that's accurate. I'm curious if there's a particular setting, Dr. Blader, that feels maybe.
Well, the recovery high schools, for instance, and I think those settings probably should have enhanced mental health services available for kids and families on site, or very tight partnerships to my mind. Early childhood, Head Start, that could kind of go either way, I suppose. And again, the specialized schools, depending, I think we're talking about some things that are bound to have rather chronic chronic needs. So I mean, I might, I could see a role, but several of these are settings that I would, in the ideal world, prefer to see them working on developing either a partnership or having their own in-house teams to address the panoply of mental health issues that are so prevalent.
Mhm. And I just want to point out that as TCHAP programs contact these settings, certainly if they have available psychiatric care or mental health care, there is always the opportunity for them to indicate if they don't need TCHAP. This would just be, encouraging that conversation to happen to see if they feel like it would benefit the students there as well.
Dr. Wakefield?
Yeah, thanks. Dr. Blader, I just wanted to continue this conversation. I think a couple of things that I'm thinking of is that very in line with what you're saying is that many of these, especially the early childhood and the specialized schools and recovery high schools, will likely have additional services that we don't see in other schools, but may not have the entire continuum of services, like not access to a child psychiatrist. And so that each program may not, they might not be needing the entire range of services and evaluation, but might still need access to a child psychiatrist. But if they don't have that range, might have a high burden of referrals. And even if they do have those other services, might have a higher burden of referrals for that psychiatric evaluation. So we just need to look at that as we're looking at if we're adequately resourced for these schools and what that might entail.
Good point. Any further discussion? So again, the goal here will be to kind of clean up the denominator in our reporting, that these entities that really aren't suitable for TCHAT would be removed out of the denominator. If they call us and say, we really need help, then we can provide them those services. But as we are prioritizing who do we reach out to in the next year to say that we've reached out to every school that wants it, that the group on the left would not be part of that denominator. And the group on the right would still be part of it, but if they are resourced and don't need that help, we would at least say that we have touched base with them and that they have the services that they need. Sarah Martin, I see your hand.
Yes, I just wanted to ask how charter schools kind of fit into all this, because there's a lot of charter schools that are they're like a company that is maybe not even just in Texas, it's all over. The kids live here in our area maybe, but there really isn't a way to have a contract with the school when it's an online school and the kids are still at home. I would kind of vote for those not to be included.
Mm-hmm.
Whereas there's other charter schools that that have more of infrastructure. The kids go to school. It's easy to have somebody at the school to contact, to kind of get a contract going. With these other schools, it would be like individual parents you're contacting. It's just very, very complicated. And then, I don't know. What do you think?
Dr. Lopez, how are you approaching those schools?
So in general, many of these that are on this list are charter schools working within those specialized settings. We have not excluded charter schools broadly. If there are specific schools that you feel there may not be the appropriate infrastructure for, I think we can certainly have conversations around those. I can't always tell that, I think, from the information that's available to me on the TEA side of it.
So it sounds like we need to evaluate those on an individual basis of whether they'd be appropriate or not. And if they're not appropriate, well, we can remove them from the denominator. If they are appropriate, still make our services available. Is that right, Dr. Lopez?
Yes, I think that's
okay.
That sounds great to me.
Dr. Liberzon?
Yeah, my question was about the other categories there. And and it's important to understand how we use this evaluation data. If the index of our activity will be simply reaching out to them is one thing, and that's because it's relatively easy to do. On the other hand, if the other indices that we're going to be taking is a percent of enrollment and so on, by including in the denominator schools that are not likely to enroll because they have already existing supports or because they need a different support, we're going to shoot ourselves in the foot, demonstrating performance which is not expected. So it's really not only the question of what goes into denominator, but also what are the various indices that we're going to be performance measures that we will be doing. So the question becomes, the moment we put them in denominator, we can now check whether the performance measure that we're doing is really fit for that particular school or type of schools. So if somebody can address that point, I'll be appreciative.
And Dr. Lopez, I can jump in first, and then you can add on and clarify. You know, what we have told the legislature is that we're going to make TCHAT available to any school that wants it. That we aren't going to force schools to put in place TCHAT, but we will offer that and make sure that we document that we've made it available to any school that wants it. And so that's the main denominator that I'm working with right now. And again, part of this exercise is to make sure that we clarify schools that would not be appropriate for us to offer it to, so that we aren't held accountable for things that we can't do. It's like the psychiatric hospitals, schools. But Israel, to your point, the metric that we're trying hard this next year is to make sure that we offer it to any eligible school. And if they want to decline it, that's fine. That's their choice. But we have done our part to offer the program to them. Molly, anything else on that?
Yes, thank you. I will just add that we are also asking teams to identify why the school declined, because I think that gives us very good information to know that those schools feel like they have the appropriate mental health resources available to them.
So as long as this is the only metrics that we will be judged by, that's perfectly fine. I don't have a problem with that.
Right. Very good. Any other questions for Dr. Lopez?
Yeah, small question. How would the, as you have here, homebound, is that different from homeschooled?
Usually those are students that for medical reasons or other reasons need to receive school at home. Usually there is a teacher that goes out to the home to support that.
That's what I thought. So how would that work in the denominator? Is that the raw number of students, or are you saying to the district, is this a service you want to make available for those of your homebound students who might have mental health needs? No, is this at the individual level or at the district level, kind of in or out?
It's at the district level. Usually we will count the census if there's a census for homebound. Sometimes there is, sometimes there's not. So it may be in our overall data about the number of students within that district. We would count the census for that homebound school.
Mm-hmm. Thank you.
Okay. Are there any other questions? Seeing none, can I have a motion to approve the cleanup of the TCHAT schools in the way that we had on the table in front of us just a minute ago?
So moved.
I have a motion from Dr. Wagner, and then I'm not sure who gave the second.
Dr. Ibrahim.
Dr. Ibrahim. Okay. Any further discussion? Seeing none, all in favor of approval of that motion, signify by saying aye.
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 Opposed, nay. Anyone abstain? It is approved. Dr. Lopez, is there anything else from you today?
No, thank you, everyone.
No, thank you for the ongoing support. We really do appreciate it. So with that, let's go to our external evaluation report, and Dr. Savas and Dr. Peskin, turn it over to you.
Okay, I'll be delivering this today. We have a short report. We've been really focused on our leaning data and the annual report. And so we can go to the next slide. I'm going to present some of our preliminary findings from the TCHAT school survey that our group has been conducting this year. And this is a sample of schools, counselors, someone identified at the community school level that knows the program. So we had 150 school districts identified across all 12 HRIs selected, and then reached out to these HRIs and obtained the main contacts at 316 campuses. And when we closed the survey, we had 197 completed surveys. So you can see the flow there of how we rolled it out and the sample we ended up with. So you can go to the next slide. So the goals of this survey are to get from the school perspective how the program is working. We like to understand the factors that are barriers, facilitators to engaging in the program and implementing it at the school level. So for example, we're looking at first we've identified the characteristics of the school. We described that by the school needs and mental health services that may be available on site. We also look at factors that influence the use of the program, such as the school capacity, that could be size, staffing. We look at the implementation support that they report they've received from HRIs and different elements of this. And then we look at such as trainings or technical assistance. We also look at some of the implementation outcomes. So from the counselor point of view, we're looking at what organizational factors may have influenced their use of the program or implementation, their ability to engage with it with fidelity. And we're developing a fidelity index that we've built based on our process mapping. And then looking at how these outcomes, implementation outcomes, are associated with different factors at the school level. So some of the outcomes that we can look at are, of course, reported from the school staff perspective. So from their perspective, the parental acceptance of the program, their perceived benefits to the student of the program, and then the staff's recommendations and any future use of the program. So if you go to the next table, you'll just see these are characteristics of the survey respondents. So these are, again, at the school level, the counselors or the person implementing the program. You can see most of them are the counselor, a few are a social worker. And then you can see kind of the breakdown of their education. And then we see that about 3/4 of them are the coordinator, the actual coordinator of the TCHAT program. And if you go to the next slide, we'll have detailed results from the survey on our annual survey. These are some of the preliminary results that we thought you might be interested in. So this is perceived outcomes of TCHAT. So the respondents, half of them agree that students are more involved in school after being seen as part of the TCHAT program. The students had decreased in behavioral incidents, 61% agreed with that. And then among the students that were seen through the TCHAT program, you can see that 53% were reported to have better attendance at school. And so this is, again, the counselors reporting their impression or perspective of the program, how it's been the program effect on the child level. So if you go to the next slide, you can see that they did, about 47% said that students had better grades. You can see that, a third really didn't know. They neither agreed nor disagreed on that. And then the TCHAT increased school staff capacity to meet the non-educational needs of the program. That overwhelmingly, they were in support of and agreed 77% said yes. And then 21% said they didn't agree or disagree. And that could reflect they weren't the main person and contact person at the school level. So it does look like they feel supported by the HRIs. They're getting that training and the assistance. So that's a good indicator. And if you go to the last slide, next slide, I will look at recommendations and future use. So you can see that 88% said they would recommend a TCHAT program to other schools, and again, would continue using a TCHAT program. So that again is an indicator that they feel that it has been working as they've been implementing it, which is a good sign. Again, this is all from the implementer perspective. We'll be interested in being able to work perhaps with the internal evaluation team to be able to get some of the outcomes at more of the child level. But this helps us understand that the program is being implemented as planned and working so far. And we have more details to understand kind of how this may vary by school characteristics or population characteristics. And that details more in our annual report. So just to summarize some other activities that we've been engaging with this last month, you can go to the next slide, where we have similar surveys going out at the to understand the provider perspective for the CPAN program. So those surveys are in process. If you're an HRI leader and you want to encourage providers, if you have relationships with providers, we have a sample of providers across HRIs, and we're still reminding them to fill out the surveys. In addition, we are continuing to work on the data dashboard, integrating the TCHAT data, so that the dashboard we shared last month, showing CPAN enrollment, engagement with CPAN by clinics enrolled. That similar data we plan to do with the schools, so that the HRIs can look at how they're doing enrolling schools and which ones are engaged visually using the dashboard. And then a lot of our work has been in cleaning trait data to prepare it for analysis. And we've been doing a lot of quality improvement on data. We have a lot of data discrepancy reports that we've been bringing to cost meetings and going through those to, and coming out of this are some discussions about this could be an indicator of a way to improve the trait system, the trait-based data management system, and also the data quality reports. We hope to also help guide any improvement in the users that are documenting their work in the trait system to ensure that we're getting good, consistent documentation and decreasing repeat data entry of schools, for example. So that has been an ongoing process for our team. And that's it for our update. But I see, Sarah, Dr. Wakefield, you have a question.
I do. Thank you so much for this. In looking at the perceived outcomes of TCHAT in particular, the disagree numbers are very, very low, but there's quite a bit of neither agree nor disagree or don't know. And I was wondering if you have recommendations or things, things that the external team can do or things that each team could do for getting more clarity around those pieces of data.
Yeah, that's a really good question. Some of that may be that I'm trying to go back on my, so we do know that 21% reported they don't coordinate the TCHAT program. So that could be a reflection that we didn't get the right person to respond to the survey. And there's some turnover. So we do plan on getting these surveys out earlier before there may be some staff turnover where we may be losing that contact who had more experience during the school year with the program. But so those are things we can easily do with the way we implement the survey. I think that, in another kind of revamping and reconceptualizing different ways we can look at the evaluation, we could also consider inviting some of these people to do some in-depth interviews with us and explore more depth their use of the program and what are barriers, and get just more granular in understanding at that level. Where we have, with all the schools that are doing this program, this is really a snapshot. We tried to get a really good random sample. I can't say randomized because we did take the HRIs and then try to get a good breakdown of rural, urban, big, small, and varied characteristics. But then we're really relying on respondents, and there's probably some respondent bias there too. So we do have an incentive, it's not huge, to encourage people to do the surveys. We could think about, do we need to do more to get people who don't really want to do the survey to do it? Is their perspective actually maybe really important? Yeah, so good question, and all things that we think about.
Well, and then I was just thinking, so then agree nor disagree, maybe, we haven't had enough time to really see outcomes yet. Exactly. And so maybe some more granularity if they choose agree, neither one. And then the I don't know is the one that really could swing, so many ways about why they don't know. Is that really neither agree nor disagree because we haven't seen that, we haven't had time to see outcomes? Is that because I truly don't know because I'm not involved in the program enough? I think just more granularity around those answers would help us plan better in the future.
That's a great suggestion to ask, to follow up on that, about why. We also did have some open-ended questions that we are not reporting here, where they wrote in a lot. And last year, when we got that, it was like a qualitative analysis of the open-ended questions. So we'll delve more into the data here for the annual report, and hopefully have more to report next time.
Very good. Any other questions? All right, I'm not seeing any, but again, Dr. Savas, thank you very much. I think that's encouraging data related to the impact that the group is doing. So look forward to the final report, but that glimpse of it, I think, is very encouraging. So thank you.
Thanks.
With that, first, let me let the record show that Jeffrey Newport is here. Dr. Newport is here. Are there any other executive committee members that have joined us since we took attendance?
Podewilz.
Thank you, Dr. Podewilz. Anybody else? Hearing none, let's move forward to the update on the ARPA funds, the American Rescue Plan Act funds for our initiatives. And with that, let me start off with Linda Haster. Linda?
Good morning. Thank you. Can you hear me?
I can, yes.
Okay, perfect. Well, I wanted to report in first on the contract status. We did receive an executed agreement back from TGCB, and so we were able to issue our subaward agreements out to each of the HRIs and as well as Meadows. So we currently received 8 out of the 13 back, which is very promising, and we're in communication with the remainders to be able to execute those quickly. So therefore, when it comes to the expenditure data, we are at our fiscal year end. So we are confirming what expenditures have already taken place that were authorized during the pre-award spending period that we had. And so to date, for those numbers, we have approximately $1.8 million that were spent between each of the HRIs to date up through August 31st. That's approximately about $122,000 out of the C-SPAN funding. 886,000 came out of the TTAC area, and then we had another 53,000 that was out of the CPW programs. And so, and we expected that one to be low because most of the funding they couldn't spend there until they had an executed agreement to make offer letters to the expanded workforce and stuff. We realized that we're going to be coming up against our next quarterly reporting period at the end of September. And so with the signed agreements, we do expect to see an increase in the numbers that are reported to us to show the work that what everybody's been doing for the prior 9 months while we're waiting to execute agreements. Are there any questions?
Any questions for Linda? Linda, I don't see any, but again, thank you for your ongoing support and moving those contracts forward. I know people are very appreciative of that. So
Sure.
thank you.
You're welcome.
So let's go to Lachelle for the update for the overall administration of those funds.
I also don't have much of an update.
Okay.
We've got all the agreements now in place that we needed on our side between us and UT Austin, us and the coordinating board. And we are working on, if we step out of the ARPA side and more on the state side, we are working on amendments. I mentioned last time, but working on amendments for the changes for fiscal year 23 budgets. And just starting to receive some of the end of year fiscals for FY22. That will be something that we will be paying close attention to look at what our trend lines are, those mimicking what you previously gave us in terms of forecasts. And I know you've had a lot of contact with Jonathan on numerous items related to both FY24, 25, which I think we talk about later. And then on the ARPA side, I just want to mention that Sarah has been sending out some status report templates or working on those with the HRIs. We have a couple of outstanding questions. I don't know, Sarah, if you have anything to add related to that. You have to touch it to turn it green. There you go.
Doing it? Oh, good. Hi, everyone. Sorry about the microphone issue. We should have the answers to those outstanding questions by the end of the week, and you should get an update from me by Friday.
So just to provide some context to that, we will be getting fiscal information from UT Austin related to the ARPA expenditure, and then we will be collecting some of the data through these status reports, and we'll be comparing the two to make sure that we're seeing the progress expected based on those expenditure lines.
All right, Jonathan, you have something to add?
Yeah, just wanted to, I know there's been a few requests for changes to your ARPA budgets. Now that we've got their initial contracts executed, we're now going to begin that process of looking at those change requests and getting back to you all on approving those. So you should expect that in the next week or two. I just wanted to provide that update on those changes. And if you haven't executed your contract yet, please do so that we can make those changes that you need.
Okay. Dr. Trivedi, I see your hand.
So thank you. We get a lot of questions from HRIs because the timeline has shifted, right, as you can imagine, and it's now coming up almost second year. How should they think about it in terms of flexibility? Do they have now the flexibility for a larger budget in year two, or how does it work? Do you have any guidance on how people sites should think about it?
I can answer that. So as it stands right now, the ARPA funds can be expended through, I forget the exact date, but November 2023. There's no guarantee that we will be able to expend those funds beyond that. So the allocation is not by fiscal year. You have a lump sum you've been approved to spend. So if you feel like you can accelerate the work by expending more of those funds now, that may be a wise path to take. The associated metrics will only be based on the performance date. So, you know, the date you can expend those funds. So although we collected 2-year metrics at the beginning, the reality is that you have not had 2 years to expend the funds or to implement the programs. And we are aware of that. So I think when Sarah has reached out, she's been looking at more of a 1-year metric, a 12-month metric, and then we will just calculate, we'll reduce year 2 by the performance period associated. So if it does end up getting extended and we can spend those ARPA funds further into fiscal year 24, then the metrics should carry through. But we know that there's no guarantee as it is right now. And a lot of the programs that we are using ARPA funds for are related to things like TChat expansion or services that we want to continue as part of the consortium work next biennium. And so when we look at the biennium ask for 24-25, we will actually be looking at what state funds we can get to continue those without reliance on the ARPA, because we don't want to tell schools, I'm sorry, we can't continue supporting you because the ARPA funds are gone.
So that would be my caveat, is that those dollars are there, we need to spend them, but you need to be planning ahead so that if you spend much more of the allocation in year 2 than you were anticipating, how does that then affect your year 3 and what we had to ask during the legislative session? But otherwise, those dollars are available and need to be put to good work. Okay.
And thank you, Lachelle and Dr. Leakey, for getting us some guidance, because ultimately we are also those who are trying to manage this as interested in the metrics and outcomes. So in an ideal world, what I'm hearing is we should try to do as much as we can so that we get the metrics, and that may end up being a little larger budget for year 2, but then we will have to think it through. Am I hearing that right, Dr. Leakey?
I think so. Again, just need to plan for not only expenditure of these dollars, but then how does that affect your year 3? And will you have a step down, or does that mean that additional dollars are going to need to be secured? Okay.
Thank you so much.
All right. Very good. Are there any other questions? Seeing none, let's go to the update from Dr. Wakefield on the Perinatal Psychiatric Access Network pilot that we're standing up. Dr. Wakefield?
Yes, thank you. So we have had the line live just at a month now, which is really exciting. We chose, as a reminder to everybody, we chose that August 18th deadline or date to launch because that was the date that the trait portal and information would be available. And through our experience with CPN, we thought, in migrating that information, that it really would be helpful to our teams to have that portal built before we went live, so that they could start to enroll clinicians right into the portal. So we went live on August 18th, both with the line and with the enrollment and engagement process. We have received some calls, which is really exciting. So we've started to do that. But our main focus over the last month has really been engagement, both at the state level and in these pilot regions. So each pilot team is working very hard to engage, to provide presentations to the obstetricians in their areas, to call them, tell them about this program going on, and to get their clinicians enrolled. So that process is running. At the state level, we have, as PeriPan, have engaged in the following presentations, some with our ACOG District 11, which are district, I can't read. Yeah, that is 11. Advisory Council, which is the Texas district, with the Lifeline for Moms Network Exchange, which is our national exchange and network for the perinatal psychiatry access programs across the state. So they know we're live, as well as Postpartum Support International. We have done a presentation for the Texas Collaborative for Healthy Mothers and Babies, to their executive committee and to their obstetrics committee. We have also done a presentation to the Texas Maternal Mortality and Morbidity Review Committee, and the Texas Association of Community Health Centers. We've engaged in some media at the state level as well, with ACOG Rounds newsletter article, Texas Collaborative for Healthy Mothers and Babies Q&A, and then recently, it's not published yet, but I told the planning committee this morning that we did an NPR discussion that will be both audio and in print. So really trying to educate the state and different organizations and key stakeholders on what we're doing, and then pushing out those individualized presentations regionally in those pilot regions to actually get clinicians enrolled. So I'll take any questions. Kosh is supporting us, and so there may be some additional things we talk about during that Kosh presentation. But this has been a great effort, and I'm very proud of the work that we've done with the Kosh team and with the pilot regions.
All right, very good. Any questions? Again, brand new. It's been up basically a month for the line to be live, starting to get calls, but a lot of work that needs to take place, not only with the media and letting people know about it, but the hard work of going to the clinicians in the area and letting them know that this program is available. And the OBGYN physicians, other psychiatrists, there's a variety of clinicians that need this type of support throughout the state of Texas. And it's been a high priority for HHSC for several years to get this up and going. So any comments or any questions? Seeing none, thank you, Dr. Wakefield. And let's go to the update on the collaborative care, the Meadows Mental Health Policy Institute work that they're doing. And Monica, I guess you'll be doing that update today?
Actually, Dr. Talibi, Hani from our team is
great.
taking that update.
Good morning,
Perfect.
everybody. Thanks, Dr. Lakey. Nice to see a bunch of friendly, familiar faces on a Tuesday morning. I'm going to go through just a couple of slides here and then field any questions folks may have. We can shift to the second slide here, please, and thank you. So I wanted to go over from a chronological standpoint what has been accomplished and what's coming up. This past January, and then again in the spring and May, we kind of got everybody together from an HRI standpoint, provided a collaborative care overview, speaking high level about the model and what goes along with that across different dimensions. In the spring as well, March and April, we had some individual HRI meetings. Some of those included internal and external health systems that would be associated with the project. And then since May, there have been monthly meetings with the HRIs, UT Austin and UT System, to get everybody on the same page as we culminated in a September 7th signing of that contract. Thankfully, we got through that. And now up next in a couple of weeks, on October 3rd, we're going to have a virtual kickoff with all the HRIs again, speaking a little bit about next steps and what that's going to look like. The next slide will cover that a little bit more in detail. Our plan for October is to really have some individual tailored meetings with each HRI. Some of those may include health systems as well, but generally those will be to identify and address any idiosyncratic needs that may be coming up across different dimensions. And then moving ahead, looking on the horizon, recruiting health systems with the HRIs will be a priority, getting things up and running as quickly as possible. We want to have monthly meetings. Not a surprise that everyone is really busy and the bandwidth is limited, but from a TA standpoint, we want to make sure we're covering specific topics that may be ubiquitous across health systems and have the support of Meadows staff as well as HRIs who are kind of associated both, again, internally and externally with those health systems. We're putting together the monthly reporting guidelines so that we can meet those metrics both on a monthly and annual standpoint. Next slide, please. So in that October 3rd meeting that we noted, really we're going to do a brief reorientation to the collaborative care model and then talk about HRI responsibilities and reporting expectations. We've also compiled some different dimensions and variables at play to share with the HRIs in health system selection. There's still a few HRIs that have outstanding health systems to identify. We really wanted to craft a linear format and one that was uniform across HRIs to support in not only thinking about who to select, but what variables of import we'd be covering as time progressed, as related to reporting, to make sure that they have what they need in place to be able to successfully not just implement, but sustain a collaborative care model over time, which is the ultimate goal. Next slide, and should be just questions. Anything out there that we can support with at this point?
Very good. Thank you, Hani. Any questions for Dr. Talibi? All right. I'm not seeing any right now, but again, appreciate the work and getting this going. The funds have now been allocated, and so the work is moving forward. So thank you very much. Dr. Blader, we're going to go to you next for the update on the pilot that you're standing up on substance use disorder services through TChat. Joe?
Thank you, David. And I won't PowerPoint you, so I hope I get some credit for that. Since our last update, our sites have completed our initial round of clinician training and screening, family-based treatment for alcohol and drug use. I think all of our sites now have our expert model in place as part of our standard operating procedure and TChat, and I'll come back to some of the referral issues in a moment. I want to mention that we were disappointed to learn that our colleagues from one of our initial sites, UT Health at Tyler, had to withdraw from the initiative because of bandwidth issues as they're working to complete their standing up of other components of their consortium services. So we wish Tyler well and hope to re-engage with them sometime in the future, perhaps. At least two of our sites are gearing up with completing their hiring processes to build out their teams, putting the finishing touches on their assessment protocols for the specialty care components of our initiative. San Antonio and Houston have been taking referrals and getting treatment underway. We've had a combination of referrals from TChat, Kids Screening Positive through our administration of the CRAFT 2.1N. So we've got a few kids identified and in our patient care pipeline through that, as well as referrals from other community sources. So evidently we're filling a need beyond enhancing services to the existing participating TChat schools. And it's not impossible that as non-participating schools avail themselves of what we have on offer, that might prove to be the, as I say, the thin edge of the wedge for involving some of those other districts in TChat in a more robust way. Some sites are also going to get underway with advanced family therapy training and ongoing supervision, consultation with external advisors who've been leaders in this type of treatment for youth substance abuse, the Partnership to End Addiction. Now that we have our contracts all but ready to go, we're finally in a position to be able to subcontract with some of these other entities. Question recently arose concerning students who, I guess per state protocol, are sent to alternative school campuses, or perhaps based on Molly's presentation, another term is recovery schools. Anyway, a number of youngsters get sent to alternatives to these sorts of campuses for a fixed period, usually I believe 60 days, because they have used or had contraband on campus. So this raised some issues about confidentiality and compliance where school personnel are concerned. Some of our sites have had school personnel routinely involved in therapy services. So we're going to revisit whether there are some parameters around the way that schools handle on-campus substance involvement that comes to their attention, so that we don't put kids in jeopardy if that's unwarranted. Now, the other side of that is that we also think that perhaps our services could be a useful adjunct in some of these alternative settings, much like Molly was mentioning earlier, if we were to arrange to start accepting referrals from those sites as well. So we're going to have further consideration, perhaps with some outside consultation involving TEA and legal counsel around those issues. I want to take a moment to thank the folks who aren't part of the core implementation team or part of UT system. These are folks who have been enthusiastically consulting with us and been involved on our bi-weekly steering committee calls. These are folks at HHSC, some other adolescent substance use experts throughout the state, from some of our LMHAs. So their input has been valuable, and I'm very grateful for their involvement, especially at 8 a.m. on Fridays. My hope is that certainly by November, December, the reports I have for this group will be able to start including some data on kids screening positive through TChat, the referral pipeline, and the number of folks served. So with that goal in mind and those comments, I'll happy to discuss anything y'all care to bring up.
Very good. Thank you, Dr. Blader. Any questions from the group? All right. I'm not seeing any right now, Joe, but again, thank you for getting that stood up. Look forward to seeing the progress over the next several months. So thanks. Dr. Trivedi, I see that you're on. Why don't we go to you if you're available on the Youth Aware of Mental Health update?
Yes, I will. And as my friend Dr. Blader says, don't PowerPoint them. So I'm just have 3 or 4 slides. But I do
very good.
I do want to take a minute before I even go into slides. As I mentioned earlier with Molly, I'm an outcomes person. I have to tell you, this has been an amazing process issue. A lot of the HRIs who still don't have the funds, et cetera, but they're engaged, they're active. This has been a real collaboration across all the HRIs that have participated. They've sent a lot of people. I'll show you that, to how many people we have already trained, certified, and they're ready to go. And as soon as the funds come in a lot of places, and in fact, they have already engaged with schools, et cetera. So I want to take a step back and say that the process has been unbelievable, and the partnership with all the HRIs has been fantastic. So in anticipation, we started the training process even before anything happened. We have a training academy. We have already had our setup in place, and you can see all the training sessions we've already completed, and you can see pictures. We can give you more pictures, but really it's been, and we have another one that we just completed this last week. So when I sent the slides, we did this September thing. We'll have another one in October, obviously. And these are all the people who have been trained across HRIs that across the state. And I can tell you, one of these days, instead of giving my review or status update, I'm going to invite 2 or 3 of these people to tell you what this is. I think it has just been a phenomenal, exciting thing in my humble opinion. So we have already started, because at UT Southwestern, as you all understand, we have been doing this for some time. So we had a cadre of trained facilitators and our connections with schools, independent actually, in fact, of TChat, but now we'll connect with them, had been ongoing. So we have been in schools, ISDs, or I like the earlier discussion about charter schools. We should come back to it. But so we have already reached a significant number of students with almost 1,200 classes and 2,100 students. We are moving fast, and we have a lot of schools that have already been approached and have agreed, have MOUs with all of us. So for example, with UT Southwestern, which I know most intimately about, is we have MOUs with Arlington ISD, Bonham ISD, which is a rural ISD up in Sherman or north of Sherman, it's closer to Oklahoma than to Dallas. Ector ISD, Gunter, Plano. Plano is one of the largest ISDs in Dallas. Trenton and Uplift Charter Network, and others, including UT Tyler, UT San Antonio, Rena Pardivala at UT San Antonio, I think could end up being the biggest spokesperson for this. They have connections with a lot of the ISDs. I think we are really primed to go big with this. And so I can't thank all these partners in each of these HRIs. We really want to invite the remaining HRIs. So any of you who are not part of it, bug the system so you can become part of it. We will increase the number of schools per each HRI. So we are working with, we get on calls with the PTAs, with school superintendents from we have a CDRC training academy. So we have a whole team that has done this for the last 4 years. So I or Toby Fuller, Dr. Toby Fuller, or a lot of our partners get on with these calls, and we want to get more people. Eventually, I think that our real goal should be to train school personnel. And we'll do this through HRIs over the next 2 years. But my wish and hope, dream is to get the school personnel trained up so that this becomes their life. And this is what they do for academic counseling, they do for mental health prevention, and there is this. And so that is my hope, eventual hope. So I'm going to stop here, Dr. Lakey.
All right. Thank you, Dr. Trivedi. Any questions? Dr. Wakefield, I see your hand.
Sorry, I seem to have a question about everything. I was just noticing as my kiddos went back to school this year that the school districts were pushing out links to videos and different things for mental health education, which I very much appreciate the efforts. Some of the videos that I noticed, at least in our school district area, did not seem actually age appropriate for some of the kiddos. And I didn't know from TEA's perspective if that was school district based that they made those decisions, or if that information was pushed out by TEA. But one of the things I was thinking in reviewing the information that I was looking at for my own children was if we could, if we are now in all of these schools and the expectation is to go statewide, and if there was an opportunity to have some discussion about YAM or other similar, other kind of consortium endorsed programs, talking about those with the TEA, because I don't want to duplicate efforts. And I think having these child psychiatrists be a part of this discussion about what kinds of information was pushed out to different age levels might be helpful, and that we want to be a part of that discussion and to be helpful in that way.
I think Dr. Wakefield, as usual, raises the most important issue. So TEA has endorsed and included YAM as one of the evidence-based treatment programs that should be incorporated in school mental health and prevention. They tend to not want to, what is the right terminology to say, sort of put their thumb on the scale so that they say one is better than the other. So they tend to be much more ecumenical and very broad. So anybody who has a program, they kind of include. And I think that what you're pointing out is something that Dr. Lakey is a bigger issue. And that is, can we work with the TEA, educate, help them to really thin it down to those that are truly evidence-based compared to some things that sound good, like QPR, question, persuade, refer, is an oftenly used thing. And what it does is similar to terrorism, like if you see something, say something, and yes, maybe it works from time to time, but when YAM was compared to QPR, YAM was distinctly shown superior to QPR in a Lancet publication. And yet TEA includes QPR with YAM. So that's the question, Dr. Wakefield. So this is a difficult question, but I agree with you, Sarah.
Thanks for raising that. You know, obviously somebody from TEA isn't here and we would need to talk to them related to how that's decided. Again, our mandate to be statewide is with TChat, not with the YAM or the educational program. HHSE is doing mental health first aid and a variety of other programs that we want to be very respectful and support. But happy to have some conversation at a later time related with TEA related to how those programs are vetted and if there's additional support that we can provide. Again, being careful that we don't try to take over all that area.
And I think
that are supported by TEA that we want to make sure
and
thrive.
you pointed out an important point, and that is we have been actually working in Dallas, North Texas area with the MetroCare and with NITPA and in other places with partnering with those who are doing mental health first aid. So I agree with you. And to be very humble about what we are doing, if we all think that only one thing will solve every problem, then we are foolish, right? So therefore, there are bigger and more options that should be considered. So yes, I think you're right, Dr. Lakey. And we are working with at least in the North Texas area, and we are working with each HRI to partner with their systems to also work with mental health first aid if that is happening in their systems.
All right.
And Dr. Lakey, my comment was definitely not for us to take over anything, just for us to be a resource and also to make sure that we are providing, a continuum and not duplicating, and really just to have that conversation going.
Okay, thank you. Any other comments? Hearing none, thank you, Dr. Trivedi. Let's now, Dr. Williams, an update on the safe alternatives for teens and youth.
Well, you stole my thunder for Kosh.
What's that?
No, I'm just joking. I have it all in the Kosh.
Oh, is it all in the Kosh? You want to do it at that time?
Yes, that's fine. It's not like a big thing, but I can say it all there.
Okay. Very good. So quick little check here. It's 11:45. The next item we're going to jump into is the budget, which I think is going to be a pretty in-depth conversation. You're ready to go to that now, or is it time for us to take a break and then start off with the budget? Yeah. I'm getting signals that the lunch is here, and I'm getting signs from some folks that they need a break. So we're going to take a break. Let's do 30 minutes. Let's go to 12:30. We'll resume the activities. That gives you plenty of time to grab lunch. But at 12:30, we will start off and jump right into the budget thoughts, and then have the update on the Kosh, and then hear about some of the other great activities occurring, especially out in El Paso. So I'll see everyone again at 12:30. Thanks.
So lunch is actually going to be set up in 5 minutes, and you go all the way, and the very end.
Very good.
So what is that for the balance? What's the limited? I'm thinking of the answers. Yeah. Is that, it's one of the highlighted
Is it also included like language in there? They didn't break it out by like different. I'll just use the old language.
Well,
Within the last line of books. So language easier.
yeah, I was thinking that. Tell them they should change.
So if someone were, they got the. Hang in the region, we need to. No, if I. Yeah. We can make it special. We just need to cover it.
That's very included in the scope of work. We have it.
Medicare. Yeah, it is, because I'm not. Yeah. Oh my goodness. Yeah.
Because that's so.
2 minutes, 2 minutes. Yeah. I used to work in HTC in Medicaid, in quality shopping. One of the big blind spots, we always try to do Medicaid Medicare, since we never really saw a full picture of the care. Side by side, like sense Medicare didn't really need to get both data sets. Really good coordinate care to really find out what's going on. Typically, they at least for higher acuity, higher needs. That's coordinated care, more expensive, and so you can do focus on that population, better outcomes, cost. It just seems like those talk to each other. So we do Medicare assessment. Yeah. Oh, no. Yes. If you have one other stuff. Here.
Yeah, just, yeah. We have sales, yeah, so that way.
They don't give us.
That's what I was thinking.
Take a big.
Anyway, yeah, just, and I'll send you a fact sheet.
Yeah, that'd be good.
Yeah, that's.
I know the Fed sector had a nice find there. Was it going to
Yeah.
pull up all that?
Yeah. Yeah.
And this actually came up from.
They don't have a light. That's the Zoom control. Did you find it from this? I don't know which one is. That's the speaker. What's that? If someone's computer mic is on, you need to mute all participants. Oh yeah. I just know.
Test. Touch it.
We will be starting in 4 minutes. So those of you that are out throughout Texas that need to take a quick break before we start, you have 4 more minutes. Thank you. All right, well, it is 12:30. If people could turn on their cameras to make sure that we again have quorum, we will start. A little. All right, I did a quick head count and I see at least 20 of our executive committee members here, so we can go ahead and get started. What we have to do this afternoon, we want to first have a discussion related to the budget going into the next legislative session. I'll give you a little bit more details on that. Following that, we'll have the update on, and we'll talk in that section related to some of the other initiatives, workforce initiatives that we're trying to put together. And then we will spend some time getting the update from Dr. Williams on the activities of the COSH and the other programs that are currently ongoing. And then we'll have an update from Dr. Martin about the great work she's doing in El Paso. So with that, let's start off with the budget discussion. A little bit of background maybe for this before we dive in. My goal for this discussion is that at the end of it, the budget will still need some little tweaks in it. As I was reviewing it last night, there were some things that need to be adjusted here and there, I think with some additional discussion. But I would like to have an approval for the basic framework of the budget and have the ability to have ongoing conversations with our HRIs if there needs to be some small adjustments in it that I think will be pretty minor. If it's results in a significant adjustment in the budget, then we'll come back to you. But if you would allow us the ability to make some small adjustments, because we need to get some information to several of our partners, to HHSC, we need to get them our information as they're looking at the whole approach to mental health services in the next legislative session. We need to get some information to the LBB and have some discussions with them on an approach. And so I need to have some of that ability to talk on behalf of the consortium in those budget discussions. A little bit about the process, over the last several months, there's been a group of us, Jonathan, Lachelle, Luann, and I talking with each HRI. Each HRI gave us what they think their needs are to continue the current programs and to meet the new obligation that we have been asked to complete, which is to make TChat available throughout the state. And it's a little bit complex because we have the GR funds from the last legislative session at 118. We then had ARPA dollars that were put in that started those additions to expand CPAN and TChat and enhance those programs and do some of the things that we talked about earlier today. We had some carry forward dollars after we got the direction to expand TChat, and we're going to be using those those carry forward dollars to meet some of that budget need. And we also had the governor and the lieutenant governor and the speaker put in an additional $5.8 million to meet what we thought that were the cost in order to make TChat statewide. So when you add those up and then you realize that there's carry forward and there's additional obligation, it's a significant amount of dollars that we're going to be talking about today. And again, want to be very transparent about that. Again, what you approved today with your approval can be tweaked a little bit because there's a couple of conversations I need, but I think we're pretty close and at a point that we need to bring it to you so you can see these numbers. And again, the amount of money that we'll be asking next legislative session is a significant amount of money because of those growth expectations that we've been asked to do. And we want to be very transparent about that. I want to be careful with any sticker shock, but with those obligations that we've been asked to fulfill and the way those components of the budget have been put in, when it comes now for the legislative session, we're going to need to give the exact amount of money that's going to take for the next 2 years to continue to build the programs as we have been directed. So with that initial prelude, Jonathan, why don't we go through the slides you put together and we'll go kind of section by section related to the consortium budget. We also put in the budget. We believe that we need, in order to complete these projects, we need to have workforce, people that we can hire to do this, people that we can train. And so there is a significant component of ideas that we gathered from our HRIs and put together related to where we can be smart in developing the workforce we need in order to complete these tasks. And with that, Jonathan, I'll ask you to walk us through the information that we've gathered from our HRIs.
All right, so as Dr. Leakey said, it is a significant increase from our current funding, which you can see the ask here with all the combined HRIs, it comes to about $340 million. Currently, if you add up the total state GR funding and ARPA funding, our budget is around 237. So it's about $100 million increase. And a significant amount of that, actually 54 million of that, is explicitly TCHAT expansion costs. So covering the whole state, as we've been asked to do with TCHAT, is a big part of that increase. And then we're also seeing a big increase in workforce development initiatives. So 23.5 million of that increase is coming directly from expansion of existing programs or some of the ideas for expanding workforce development that you all have submitted to us. So we'll go through each program. So TCHAT, the total listed there is 175 million. And that is broken out here between just your standard TCHAT, which also includes a lot of the ARPA initiatives, such as the expansion of anxiety services, the additional sessions. It also includes trauma services that folks were doing with ARPA. And then we've broken out here the two significant programs that ARPA also started, which is SUD. And that one is 8.6 million, and then YAM at 19.1. And I've listed here the HRIs that are participating in those initiatives for you to review. Going on to CPAN, the total ask for the next biennium is 63 million. And again, breaking that out, we have our traditional CPAN at 39.4 million, and this includes the expansion of the one-time consults that folks are getting started with. And then you can see the peri-pan expansion below, and so that's 18 million. And so this was originally is currently being run by the 4 pilot sites, Baylor, Dell, Tech, and Southwestern. And so this would expand to the whole state with the exception of one HRI. And so moving forward, we're gonna have to think about how to cover the region that does not have peri-pan, as well as make sure that we're covered again, like we do with CPAN in times of high demand to cover other folks. And then finally, the last ARPA project that's broken out here is the FISP or Safety A, which is 5.5 million. And below, again, you can see the HRIs that are participating in that initiative. So moving on to the workforce development, here we've included all of the work that's already been going on. So work with CPWE and CAP. And so you can see with CPWE, that budget request has come to 32.6 million. And just a little breakdown of what that is going for is we currently have 19 LMHAs that we're working with, and the plans are to expand into 28 of Texas's 39. So pretty good expansion and coverage of our partnering with our LMHAs in Texas. And then, the next place here is this $18.5 million of workforce development initiatives. So 9 HRIs submitted several different proposals for workforce development. This includes, beyond just their psychologist training that we do with CPWE and CAP, we have training for psychologists, for nurse practitioners, LPCs, LCSWs, LMFTs. So it's a really exciting expansion of moving beyond into other areas of the mental health workforce. And then finally here we have listed the CAP fellowships, which is also being expanded at 13.1 million. And here you can see the research learning healthcare system. So these numbers are still going to need to be refined a little bit more as we discuss what the research is going to look like going forward. But you can see here the 2 hubs, both Dell and UT Southwestern. And then we've also included an allocated amount based on some conversations around what some of the nodes will need in addition to what they're currently being funded for the expansion of that work that has been discussed. And then finally, we wanted to give you all a breakdown of our administrative costs. So the total for the next biennium that we're expecting to need is 5.3 million. This is broken out not just between UT system administration, but also contracts with UT Austin for internal evaluation. We have contracts for outreach and communications, as well as the UT Houston external evaluation folks. You'll see listed in the UT system budget there is a line for some additional staff. This would be for 2 additional project managers so that we can better serve the programs individually and have a closer eye on how folks are operating and be able to really provide that direct kind of consults and giving kind of spreading some advice that that we see of good best practices amongst HRIs. And then here's just the breakdown by HRI. You can kind of see where folks land within that $340 million ask. I'll let folks take a peek at that for a minute.
This is all initiatives.
Yes, this is the full amount just by HRI. And then finally here, let folks take a peek at this a little bit and just kind of break it out even further by HRI and initiative. So you can see kind of where all those dollars are flowing.
And I think that's the last slide,
That's
right?
the last slide.
So I'm happy, why don't you leave that up there if we could? And I'm happy to take questions. As I noted, it is a substantial growth in the budget based on the direction that we've had, the combination of ARPA, GR from the last session, and what we understand the needs of the HRIs to fulfill those needs and the direction from the legislature. Again, I anticipate there's going to be ongoing dialogue with the LBB and others to refine some of these numbers, and we'll need to be able to, with your permission, have those discussions and have dialogue with you. Again, I'm not going to surprise any HRI related to changes in their budget, but we put in what you said you needed. And we're using that as the starting point of what you said you needed in order to reach out to every school in your service area to complete CPAN, to stand up the perinatal work, and to have some targeted workforce expansion initiatives. The legislature may say we need to hold back on some of those areas and move forward in others, but we'll have that dialogue with them. And we believe on the research side, again, the research that's being done is not basic research. It's not clinical studies. It is trying to figure out the systems of care and how do we learn from the systems of care and get smarter in delivering mental health services in the state of Texas. I think there's some other areas, and we're having those discussions related to what some smart areas would be based on the needs of Texas. And how do we continue the great work that's going on and make sure that that delivers the type of answers we need to improve the systems of care related to trauma and depression, and that we can justify that. But again, we want to be very transparent with people that this is where we are on the budget and need your guidance and support to tell us if we heard you right, and if so, your approval to be able to have ongoing refinement conversations and then be able to provide that information to HHSC and people at the LBB to start moving on the next steps. Danette, I see you, your picture just came up for some reason, but we've tried to again, increase the partnerships with the local mental health authorities where it makes sense, and put some additional dollars there because that seems to be beneficial, and it's been well received from several different ways. And so, Sonia, I want to go to you first, and then Monica, I see your hand next. Sonia?
Yeah, the question I had was about the YAM training. I noticed that the budget is 19 million. And I thought the original budget was 11 million. So is that I'm assuming that's an expansion.
Jonathan?
So a couple things, Sonia. One thing is it was actually, what happened was a number of HRIs did not agree to participate. So we got to move to allow, because one of the criticisms of the consortium always continues to be that we don't include some of the underserved population. So we are working with each of them to try to bring them in. They didn't agree. So originally what ended up happening is four of them didn't participate. And the second part is we want to now expand to more schools because there is a limited number. Like one of the HRIs for their population that they can afford to do is 600 people. So we need kids. So we need to expand that because 600 kids is wonderful, but it's not anywhere close to the number we need. And so if we are really going to make an impact on these kids, then we got to have it a larger population.
So Dr. Trivedi, what I'm hearing you is more HRIs participating, and each HRI be participating with additional schools. Is that correct?
Absolutely.
Mm-hmm.
So I'm interested in knowing how many schools are you in currently, in terms of actually providing services, not thinking about it, but how many actual schools are you serving currently?
So two issues, Sonia, to really keep this in mind, guys. The money has not arrived to these HRIs, right? So how do you start doing that without and yet, what we actually, I showed you this on the slides, and let me even share that again, because we have partners who are so excited about it that they are doing this much more out of their goodwill than they could normally. So let me just go and show you the exact numbers, because I think your question is absolutely valid. So, sorry, let me pull up the right slide set. I apologize. So these people, to give you an idea, Sonia, got trained without the funds in their system. These schools have, and classes and students have already received it without the funds. So to answer your real question, how many students? Until they get the money, I can't answer you the real question. So they just started getting these funds. I don't even know. Some of the HRIs keep on complaining, calling me all the time saying, where's the funds? Where's the funds? And I keep on saying, they're coming, they're coming.
Okay, so you said that there's some work that has already begun.
Yeah.
And so could you tell me about where the work has already been? I'm trying to understand the rationale for an expansion when services have not barely gotten off on the ground. I'm just kind of working from my own personal experience or professional experience with the legislature. Normally, if we're asking for an expansion on dollars, we need to be able to show, what type of services and something that justifies the expansion, and also something that is realistic in terms of, implementation. I've implemented mental health first aid, across the entire state. And I can tell you that it took multiple years. We have less than 3 million. We have less than $3 million. And so I'm just saying, it just seems like a huge jump when services are not currently being provided. And I'm sure I'm not going to be the only one that has that question. So that's just a comment.
That is a wonderful point you're making, that whether this will deliver or not. So I think you're absolutely right. And because you and Danette were really so involved with mental health first aid, we have actually partnered and worked with all of the mental health first aid providers in North Texas. And the number of students in schools who have received mental health first aid for teens. There is a lot of people who get mental health first aid, adults, it is actually much more, as you know, a kind of a observer level in training. When you train mental health first aid for teens, there's very little. And so you're right, it has been tough. On the other hand, we have actually publications that show we've done it for YAM in schools, and I can show you more about what we have done in schools. And I'm sorry, because that wasn't part of the slide set to tell you which school districts. We actually showed you last time which school districts have already signed an MOU. So give me a minute. So I'm happy to go through and find those school districts that have already signed MOUs so that we can show you, and maybe I will be able to.
Dr. Trivedi, instead of repeating the presentation we made a little bit ago, how about we take this as advice to go back? Sorry, my microphone got turned off. Instead of repeating the presentation we did a little while ago, why don't we take this as advice to go back and sharpen the pencil, make sure that what we put in there is fully realistic, if there's some additional HRIs that are going to come on board, that we're very clear with those expectations, and just relook at that number. And then what we think is the number, we'll talk to Sonia and folks to make sure there's good partnership there with Mental Health First Aid. But this is a program that we want to be able to expand in. Again, that some of the expansion has been delayed because of the way the ARPA dollars were allocated. But again, we appreciate you moving them forward and training and moving those programs forward this year.
Absolutely happy to do it. I think, Sonia, you're actually raising an important question, and that is, will schools be interested? Will schools do it? Will the program ever actually deliver what we are talking about?
So let's sharpen the pencil and make sure that the plan is fully implementable, and then we'll have further discussion. But that's one of the adjustments that can be made.
But if you can indulge me on this for just a second, I'll show you. These are the schools, Sonia, that have already signed MOUs.
Okay. All right. So I think I don't want to get down into the nitty gritty of which schools are and which schools are not. I don't think that would be a good use of this time right now. But let's go and refine those numbers and then have additional conversations. Okay.
That's absolutely.
And this is Danette, I think in follow up, and I'm stepping out of turn here. I'm not sure that my hand was raised in front of Monica. So Monica, I'm sorry. I think you might be next, but it's a follow up to this line of conversation. So, I'm hearing a lot of good things happening in terms of the working together around mental health first aid and YAM. I think the question, and Dr. Lakey, you said kind of get ready for some sticker shock. That amount is so big. It is, 4 times the amount that we ever saw in funding for mental health first aid. So I think it's part of that. You just having gone from, I too recall somewhere in the $11 million neighborhood, and that was a high amount. And I'm not saying it's not worth it. It's just that it's a big amount. So then there's been a substantial increase in it. So I feel like it's part of the sticker shock thing, Dr. Lakey. In terms of the amount. But while I do have the floor, I do want to say that from the budget standpoint, I was really glad to see the CPW increase. Really grateful for that. And we've had a very positive response from those that do participate. Always work to be done to improve it, but a lot of good positive comments, a number of sites that have said they would like to join. And so I would want to continue to have some conversations in between, just to reach out to those that are indicating their interest to join, to be part of it, to be able to benefit from this service. And then I have one clarifying question.
Yes, go ahead.
As you're looking at this from a preliminary budget standpoint, I may just have missed this, and I apologize for that, but if that's the case. But when you're looking at it from a preliminary budget, is that just the budget given the funding you have now, or is that getting translated to an exceptional item for our legislative request?
So the mechanism in which this will be put into the budget, we're having those conversations with elected leadership and exactly how that will work. And we will follow the direction of the LBB and the senior elected leaders on how they want that to, the mechanics of that to be handled.
So the mechanics of that could include a number of things, but it could include the possibility of actually getting embedded in the budgets as they're released at the beginning of the session in the base.
That could be part of the discussion, yes.
Okay.
Okay. Monica?
Yes, Dr. Lakey, my question was around, do you anticipate needing any legislative changes, or is this all about the budget today?
Today is about the budget. I think any other legislative changes can be discussed at a further date. But the main thing today is to get a budget number, so that and with the ability to have those conversations, to adjust those like we just talked about, but to be able to move forward with that to get that information to the people that need it.
Okay. Or any anticipated legislative changes yet in later date?
I think we can talk about that at a later date.
Yeah. Okay.
Alex, Dr. Vo?
Yes, thank you. I was just wondering if you can expound on the to be determined 9 million in research. Like, what are some of the things that are to be determined? Can you just kind of?
So off my microphone. I think. So last legislative session, we did not ask for any additional funds, and it became challenging. I think as we were talking with the hubs, and have been looking at the work, there's a clear support that we need to kind of continue those. And there's some opportunities to add some additional components to that. There has been some discussion related to when we started off, they had talked about maybe 3 areas of work. Right now, there's been 2 areas and an addition of another area. But I think that still needs to have some refinement. And so we put in a number based on kind of what that experience would be. And we'll have continued conversations on what that could potentially, where that would land. Dr. Nimroff, anything you want to say on that?
I think we're extremely pleased with the progress we've made in the 2 hubs that we currently have, and you'll hear more about that later. I think there are potential areas to explore, and I think one or another members of the research team have put forth ideas that would be absolutely welcome. And the question is, would this start off as a pilot project, the way PeriPan did, at a limited number of nodes, or would it take on a larger presence? And I think those are the kind of conversations that are ongoing.
Yeah. I think as the clinical work expands, that we need to also make sure that we're supporting some of the research in the health system research area to make sure we are getting smarter related to how these dollars are being used and how we can improve services in the state of Texas.
Can you share what that potential 3rd area is? I know it's right now it's depression and trauma, but can you share what that?
I think there's additional conversations that to be had. One possibility is first episode psychosis and what happens when individuals first descend into significant mental illness and how they aren't picked up and how we can be smarter as a state and in partnership with hospitals and others to identify those individuals and get them early on into the treatments that they need.
If I could add, David. What we've talked about perhaps is a program that would look at early psychosis, including bipolar disorder. So none of the current research networks really focus on bipolar disorder. And often early psychosis is the harbinger, as you know, of bipolar disorder. So we thought that perhaps that might be one avenue to investigate. And I know Carol Tominga has been very vocal about that area. So that would be one area that we've talked about.
But a final decision has not been made. And before a final decision had come to the executive committee, that we're looking, and that's why we have to be determined there. But I think we ought to put in a placeholder to say that that's part of the reason the HRIs are doing this is to improve the systems of care, and we need to be smart in doing that.
So would that mean then, if that's the 3rd area that is elected to go for, would UT Southwest now be 2 hubs in one place?
I think we would try to be careful with that. Again, no final decision has been made, but I have tried to be throughout this, be fair with all HRIs and make sure that resources are divided equitably among HRIs and how they can participate in these projects. Okay. Dr. Ibrahim, I think I saw your hand up just a little bit ago. Did you have a question?
Yeah, I was just, I thought I would just let the conversation go because we're running out of time. But several of the HRIs have actually had unutilized funds at the end of the last cycle. I'm just wondering how powers to be reacted to this and whether we see any potential change in the future in the way they would deal with unutilized funds. Or just the discussion we had before about TM and other projects just triggered me because I think, we just have to be careful. If we have funds available, of course, we need to use them to goodwill, but also I don't see the reason why we would be worried about extra funds, if that has not been a major issue in the past.
Yeah. So there are institutions that have not fully spent their dollars this biennium. I think in our conversations with the legislature, standing up any program in the midst of a pandemic and recruiting individuals has been difficult. But we need to put in the dollars we're going to need in order to do these programs well in all the areas we've been asked to do it. And so part of the reason that we only asked for a $5.8 million from the governor's office and the LBB and a couple of months ago was because there was unspent dollars that were carrying forward in TCHAT and allocating to the other areas. And so that again is partly why this number is that much higher than the other two numbers added together. Does that make sense, Dr. Ibrahim?
Yes, it does. I think this is what you said is exactly how we need to be thinking about this.
Yep. Okay. Any other comments? Okay. So if there's no further comments, and then I need a motion to tentatively approve this budget with the ability for us to have ongoing negotiations, one of which needs to be YAM, but there's some other areas I think some additional refinement of the budget needs to take place as I look at some outliers and trying to understand how all the dollars are going to be utilized. But we're mostly there. I need to make some of those refinements. But if I could have that motion to tentatively approved with additional negotiations and conversations to be able to then present that information to HHSC and the LBB.
Second.
I have a motion by Podowitz. I have a second by Dr. Nemiroff. Any further discussion? Hearing none, all in favor signify by saying aye.
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 Those opposed, nay. Did anyone abstain? Okay, I didn't hear that anybody had abstained. So we have then your permission to move forward with those additional conversations and then present that information again to HHSC and to the LBB to start further that conversation on the budget. As you noted in the budget on workforce, there were several areas related to workforce initiatives. We've also developed a white paper related to some of our thoughts that we could move forward potentially in a legislative session that would improve the ability to get people licensed and ability to provide services in Texas. And you have a white paper. Sarah McLaughlin has been very helpful in putting that together. Sarah, you want to talk a little bit about that white paper and some of the other workforce issues?
Thank you, Dr. Lakey. Hi, everyone. Sarah McLaughlin with the Consortium. As Dr. Lakey stated, we're looking at short and long-term strategies to remove barriers in achieving education, licensure, and education in the public health sphere. We have 6 main categories of strategies with a couple of subpoints that I'm going to go over briefly. The full white paper should be uploaded with all of the other EC documents so you can look at it at length. The first point would be financial assistance for loan repayments for college students who commit to behavioral health careers in the public sector. That would include tuition assistance that might look somewhat like a military service model. Those receiving tuition assistance would agree to be in public service in the Texas Children's mental health sphere for a minimum term. Tuition assistance would also be provided to individuals already employed by the Texas Children's mental health system who seek an advanced degree and are willing to provide public service for an additional term. This might also look like enhancing the Texas Higher Education Coordinating Board College Loan Repayment Program. We would look at allocating additional funds into the program, adding eligibility requirements and language into public sector employment, and allowing loan repayment assistance to employees who are hired and remained employed by Texas public sector behavioral health systems for a minimum term with a prorated payback if an individual does not remain in Texas. Point 2 would be paid internships for students who serve with community-based public sector employers. Some subpoints there include statewide paid internships by creating a pipeline from clinical internship to employment through Texas institutions of higher education. And those can look like nurse practitioners, social workers, counselors, psychologists, and other community health professionals. Paid internships would be located at the various health-related institutions of the consortium programs, local mental health authorities, federally qualified health centers, and other provider organizations. And we would look at expansion of community psychiatry workforce expansion to other professionals as well. So using this existing infrastructure to expand opportunities for social workers, psychologists, peer support specialists, psychiatric nurse practitioners to gain that experience in children's mental health provider organizations. Point 3 would be innovative ways to provide necessary clinical supervision hours for the licensure of counselors and therapists. That might look like a statewide remote supervision network. There's a limited availability for board approved supervisors at the clinical master's level for graduates to obtain their unrestricted clinical licensure. And if supervision is not available, these professionals might not be able to obtain their supervision or delay their qualified supervision. A state remote supervision network aims to provide that supervision for graduates with degrees in social work, psychology, and counseling pursuing their license. And once they would be licensed, they would be required to work for a qualifying agency for a minimum term post-licensure with the duration of the obligation on a 1-month required service per 1 month of qualifying supervision received. Part 2 of this bullet would be a supervisory track for public service workers to participate in that network. So this allows LCSWs, LMFTs, LPCs, so social workers, marriage and family therapists, counselors, and the existing workforce to obtain their supervisory status, continuing that supervision for incoming mental health professionals. Part 4 is direct and streamlined licensure for various types of mental health professionals, including investigating ways to encourage veterans and other professionals who previously worked in the mental health field to become licensed mental health professionals in Texas. That might look like directing licensing boards to streamline the process and working with the Texas Behavioral Health Executive Council, who sets those requirements for clinical licensure in Texas. Options there include creating a multidisciplinary group to discuss the scope, drafting approved position templates that include language required for licensure, and evaluate opportunities to streamline the educational and licensing process for veterans who have provided significant mental health services during their military service. Part 5 would be expanding the consortium's child and adolescent psychiatry fellowships through multi-boarding of physicians, creating multiple boarding opportunities for physicians, and aims to expand the HRI's capacity to include opportunities for multiple boarding. And finally, adjusting state salary schedules to account for varying costs of living across the state for rural areas with difficulty sustaining a workforce. So with locality and pay and rurality, we would establish state salary schedules updated each biennium that are adjustable based on locality areas to allow the pay scale be adjusted for varying cost of living across Texas and for rural areas with difficulty sustaining workforce. And I'd also like to open up to additional comments and feedback for our contributing partners, Dr. Martinez, Danette Castle, and Sonia Gaines, if they have anything additional to add.
And maybe, Sarah, before we do that, a little bit of background on how this document got put together. And so after Uvalde, and we knew we were going to be testifying multiple times to the legislature, and knowing the challenges that we've had with workforce, we pulled together a group of folks in a very quick brainstorming session. Sonia was part of that. Danette was part of that. Nami was part of that. Danette was part of that conversation. Dr. Martinez was part of that conversation, and we just started throwing ideas up there and started thinking and then taking time to develop them. We took the liberty in the times that I testified. At my last slide was workforce and had these areas as a highlight of things that we were thinking through. But we now have it, I think, in this document that Sarah just shared. And again, would love to hear from Octavia, from you, and Sonia, and Danette, and others, whether this captures those conversations. Again, we shared this document with that group. We think that there's some legislative interest in this. And if it's the will of the executive committee and with your blessings, and start sharing this with others to potentially get some momentum on trying to address some of the workforce issues that we're facing here in Texas. So sorry, Sarah, I just want to give a little bit of that oversight to make sure that everyone is on the same page with us. And so, Sonia, I'm going to go to you first, and then Dr. Trivedi.
Sure. First of all, I'd like to say thank you, Dr. Lakey and Luann, for your leadership on this. Really did appreciate the opportunity to participate in a dialogue that I think has ultimately resulted in some really great things that are identified here. I just want to say, for our LMHAs, without question, workforce is our #1 challenge. And, you know, I've heard from many of them about some of the initiatives that are laid out here, like the loan reimbursement. You know, some of the other things would be most helpful to them. Many of them are struggling with, you know, 40%, 50% vacancy rates today. So whatever we could do to help. And so I think this will definitely give a huge boost, you know, to at least to the areas that we work with. And so I'm very, very excited and extremely grateful.
Thank you, Sonia.
As a quick follow-up, I would also say that we really support these recommendations and appreciated the opportunity to engage in the conversation about the various options, and really do believe that they hit the mark in terms of being able to increase the number of people actually who engage in mental health service delivery over time, which is of course what we're trying to do. We have some really immediate workforce challenges that we're trying to address as well, but it's really necessary for us to invest in a way that helps to build out our bandwidth really in terms of service delivery.
Okay. I'm actually going to go to Octavio next, and then Madhukar to you, since Octavio was part of putting this together. Octavio?
Thank you, David. Just to add to Sonia and Danette, everyone, we really took this quite seriously and took a comprehensive approach to the workforce issue, and to look at really the continuity and the future of Texas. And as you notice, taking into consideration our rural partners and colleagues out there, as well as the urban and metro areas, and not let it be too physician-centric, because we felt that that would probably not fall well because it is so expensive. And many of you are already addressing that issue, but we really wanted to bring in, obviously, the fellowship that already is part of the consortium, but also looking at the entire workforce and what can be looked at. And given some of the discussions we've had offline with some of our colleagues at the Capitol, I think, as David pointed out, this will, I believe, be well received. But just want to let you know, it was really more of a comprehensive look at the workforce and the continuity that they play as we take a look at really that kind of a level of delivery for our communities now. Thank you, David.
No, thanks, Octavio. There's several folks that know that we've been developing this and have been asking for a copy of it, but we've committed that we're going to share it with this group first and finalize it and get your blessing before we share it with outside entities. Madhukar, now we'll go to you.
Thanks, and it's better to go to Octavio first. He understands this issues better than I do. So I actually, the point I was trying to sort of highlight for all of us and you mainly, is that when I testified, and Sonia, you were there, so thank you, and it was a wonderful presentation on your part. And the legislature was very interested in what to do with crises. But when it came our turn to talk about it, we were talking about earlier prevention, earlier intervention, etc. They were very excited. And I just want to figure out if there is a way for us to help and provide some context to the legislature, because they asked me a question I didn't know, and maybe a lot of you may know. What were we doing with students at Uvalde before this happened? Like, was there CPAN, TCHAT, mental health first aid, Sonia and Danette? Was it being done? Did we not do it? And they were asking about it. And maybe that gives us an avenue to say, if we had been doing things, maybe they were doing all this, but I have a feeling we were not. And so is there a way to overcome that challenge and do it? so that we do it broadly available around the state. These kinds of initiatives, and I'm biased, but including YAM, or not, is maybe another way to think it through so that we can provide some context and some thinking for the legislature to decide, because they recognize that only focusing on the crises, which is what we traditionally do as a society, has continued to increase depression, suicide in the United States for teenagers for the last 15 years, while Western societies around the world have reduced it. So we are not doing something right. So that's the point worth helping them think through. I don't know if that makes sense.
Yeah, so we've had in each of those 4 times I've testified, the issue of Uvalde has come up. Maybe just a couple quick points, and then I want to get focused again on this paper. We had offered TCHAT to Uvalde. That had not been taken up yet. It is in place now. We have had CPAN in that region of the state, and we're working to develop the other programs. But the focus.
I would like to respond, but I actually, in terms of the question about mental health first aid, because I know the answer to it, but I'm thinking that this may not be the venue for that kind of a conversation to take place about what Uvalde was or was not doing in terms of engagement.
I think that's probably right, Danette, that going into a conversation of Uvalde is not on the agenda. The conversation we need to have right now is focused on the workforce and this document and approval of the group on the document. So thank you, Danette. Yep. Joe?
First of all, I want to say that this is just extraordinary. It's an extraordinary effort, an extraordinary initiative, and so well thought out and so needed. I've been involved in clinical supervision and training of psychologists and others for over 35 years now. And this is the most impressive, comprehensive effort that I've seen to deal at a very macro level with some of these super pressing workforce initiatives. And to my mind, the conceptualization of CPW, it was, to my way of thinking, perhaps a little physician-centric, if you like. And I think that this is such a vital, I don't know if I want to say corrective, but rebalancing that's calibrated to community need, in my opinion. 3 things I just want to pick your brains about, if you don't mind. There's a provision in there, or a proposal to lure folks in undergraduate training or perhaps graduate training to within Texas. I forgot what the mechanism was, but something along the lines of tuition remission and that type of thing. Another thing to consider might be loan repayment assistance for folks who are already qualified to lure them into Texas if they're in addition or perhaps as an alternative. I just want to throw that out there. The other thing that we often encounter with bringing on pre-licensed folks concerns their ability or our ability to bill for their services. I think that there's been some changes in that direction, but if y'all could look into that and see whether it were possible to have their effort, supervised pre-licensure clinical work covered or offset by at least the government payers. That's also potentially very beneficial and a nice incentive for places like mine to bring on some of those folks to do routine clinical work in our settings. And thirdly, from eyeballing the document, I wasn't entirely clear what you were proposing with respect to the bringing on supervisors. I think it's really important to increase the cadre of LPC supervisors, because that is a distinct license. And what I've done here with some of my crew is offset their costs to go on and get their LPCSs so that they can provide that type of guidance and training for our new hires. So I think it's a great idea, but it wasn't clear to me if we were doing anything to offset the fees or the cost to individual supervisees. I think we all know it, you correctly point out in the document that for many folks who have to pay for that kind of supervision, they're already doing essentially volunteer work in a clinical service. And on top of that, they have to pay for the supervision a lot of the time or take out a second mortgage in order to offset those costs. So I wasn't clear what that meant for what the financial bottom line was for the individual supervisees. Were you was the plan to incentivize supervisors and have them provide that supervision on the state's dime, or were we still looking for supervisees to contribute?
So Sarah, I think several of those are addressed in the document, but you want to touch on those items?
Thank you, Dr. Blader. We did take into account those supervision costs. So we took into account the training for the supervisor status in addition to their licensing costs and any exams that they might have to take. So that itself is incled. And I feel like I missed a question.
And then the loan issue.
For their ongoing time for the hourly, I'm sorry to talk over you, David, but my question was offsetting the supervisor effort. So so you've taken somebody, you encourage them to get their supervisor's license. Now, are they just sort of more people on the market offering that kind of supervision, or was the cost of that supervision also in part to be borne by things you're proposing?
That would be both.
All right. Sarah Wakefield and then Dr. Trivedi.
Thank you. Thank you, Sarah, for this paper. It's fantastic. I'm really excited about all of these ideas. One of the questions I had in the multi-boarding section was, it seemed focused on pediatrics and psychiatry, which I totally understand, but was wondering about the potential, and was there any discussion on family medicine? Because those are potential programs, double boarded programs around the state as well, or around the country, and would reach our population, the target population, and might be more conducive looking at rural populations when we would expect more family medicine docs to be in our rural areas.
That's not in it at this time, but could be easily added. I don't know of any of the programs right now that are doing that or planning to do that. I know Tyler is establishing a rural training program to address some of that issue. But if that's something that the group would like us to add, that's a pretty easy add.
Texas Tech University Health Sciences Center in Lubbock has had those discussions between our family medicine department and psychiatry department. So that'd be something we would be interested in looking at addressing rural needs.
Okay, very good. And Dr. Trivedi, I see your hand again.
I think it's an adjacent question to Dr. Wakefield's question, is that there is also a lot of these guild issues. So only licensed clinicians, counselors can supervise counselors, and psychologists can supervise psychologists. And maybe there is some way to try to figure out, especially at least within the boundaries of consortium, where that can be a little more fluid, so that more people can get supervision across the board, sort of guilds, rather than just, because what ends up happening is, so clinical social workers is a good example where there are wonderful, like UT Arlington has a fantastic program, they come out, but the only way I, in my big program, can provide them with support is if I have a licensed clinical social worker. My license doesn't come. So that kind of thinking may be worth thinking about as we broaden the need for workforce.
Okay, very good. So what I think probably is the next step, we've vetted this paper document with you. We've already vetted it with the work group. We want your feedback. And so if there are some of these things that you think could be added or changed, I would like you to get those back to us. How about if I sent a week from today as a due date for any feedback that the executive committee has related to this document? And then if, I don't think any of the things that I've heard so far are major changes. And I'll see you I'll go to you in a second. And if it's the will of the executive committee allowing us then to move forward with this paper, provided to the legislature, because I think these edits that I've heard so far are pretty minor. Alan, let me go to you.
Well, first I'd like to make a motion, but then to approve, but also could we get a copy of all of the different ideas? Because many of us, I mean, there's a lot of creativity that was done here by this entire group. And there may be some things that we have resources and opportunities for some of these to actually maybe move them forward as well. So if we get a copy of what the ideas were, would be great, because I know we have a couple in there, but gosh, as I started thinking about this, there's all kinds of other opportunities. So
yep. We will share with you the information we get back from the executive committee to make edits, and then with the final copy. But Alan, it sounds like you're ready to make a motion to move forward with it, with the minor changes, with feeding the paper back then to the executive committee when we believe it is finalized, before then sending it to legislators and others. Alan, is that your motion?
that is my motion.
Okay. Do I have a second from Dr. Ibrahim? Any further discussion? Hearing none, all in favor signify by saying aye.
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 Opposed, nay. Anybody abstain? Thank you very much. All right, Sarah, anything else on workforce or Luann?
Yes, actually, we thought we would take this opportunity, and Dr. Plutterwelts, to your point about what the current initiatives are that HRIs are doing. As you noted, where Jonathan showed you the budget, there was a section that talked about other workforce initiatives, quote unquote, that the HRIs have requested funding for to do. And so we wanted to open it up for you to talk about what those are, so that you can hear from each other about those. Like I know, for example, UT Houston has quite a few that are going on, so that if you are interested in what they're doing, you can get in touch, for example, with Dr. Babatope and find out how they're doing that. I know Texas Tech is also doing one or two. So we wanted you to be able to have the opportunity to tell the other HRIs about those in case they were interested, and wanted to get with you to find out more.
Can everyone hear me? Okay. Okay, so we have some workforce expansion initiatives, and the first is, of course, expanding our psychology internship program. We're also trying to expand our LCSW fellowship program and also the CAP fellowship. We're also attempting to expand into other LMHAs. I think we've discussed with UTMB and with some other sites, Baylor as well, Tri-County, Spindletop at this moment. And we're trying to locate another LMHA that if any of the other HRIs are not interested, we would like to expand into. So I think that's just the main summary of what we are doing.
Anybody else want to share?
Yeah,
Sarah,
I'm
I
happy.
didn't put the screen. Yeah.
Sure, yeah. So we have several different things. We kind of infused workforce expansion through all of our programs when we took a look at our needs with the American Rescue Plan Act funding. So I would say that there's almost not a program in which we haven't built a workforce expansion component into it. We have funding for LPC associates to come on, and LPC supervisors for paid clinical supervision hours, so people aren't having to pay for that. We have training components built in with education to those folks about standard evidence-based measures and treatment. We have expanded our, we have postdoc child psychology fellowship that launched with this funding, and are currently getting accredited for a psychology internship. Our area had neither of those steps in training. So Texas Tech University has a robust psychology training program with great psychology grad students. We are also facilitating a child practicum with those grad students in our department. Dr. Mitchell can tell you much more about that because she's leading all of those educational efforts. And then we will have the first child psychology internship, and we have already launched our first child psychology postdoc for our region. So we were training lots of people at Texas Tech University and sending them out of our region. Few to return. So now our hope is that we will retain more of those folks in our region. We have worked with our marriage and family therapy department at TTU, as well as our Department of Social Work, to increase funding for trainees to get access to both evidence-based training and supervision and education. So I would say there's almost not a program except those very, very strict service delivery programs. The other thing that we're doing is we incorporate general psychiatry residents into some of our care and training as well. So we're increasing even those psychiatry residents who don't plan to go into child and adolescent fellowship. We know that a lot of general psych residents are seeing kids out there because of the shortage of child and adolescent psychiatrists. So we are increasing that education as well.
All right, very good. Anybody else? Alan, I see your hand.
What we propose, we are one of the few programs in the country that have a American Nursing Association accreditation for what's called a residency for post-psych nurses. So after the nurses have gone through their 2 years of nurse practitioner training, we actually have a 1-year psych residency. And so what we want to do is to be able to add a 6 months dedicated child and adolescent component to that, so that we can add that extender. It would help me immensely provide services to Tarrant County.
All right, very good, Alan. All right, anybody else? See none, let's go down to item number C there. Oh, Sarah Martin, I didn't see your hand. Sarah Martin?
Oh, yes, I'll be quick. We started a child psychology postdoctoral fellowship, and it just started this month. We hired the person this month, and she hasn't even been here 3 weeks yet, and she's already asking about potentially being hired as a faculty member. So she was in our internship. Yeah, she's in our internship. Now she was in a local internship, but she did a child rotation with us. She applied for the position, and now she wants to be faculty. So I would encourage everybody to try for that, because it's worked out really great for us so far.
Very good. Anybody else? All right, hearing none. Why don't we go down to item C, 5C, a quick update on the research initiatives. And Dr. Trivedi, we have the Youth Depression and Suicide Research Network first, and then a quick update on the trauma research.
Thank you. I won't take too much time. I think the update was short statement is it's good beautifully. We have these 12 HRIs, all of them participating. We have a registry that is very active. We're coming up on 2 years, and I'll show you some of the data. It's 8 to 20 screen positive for depression or suicidality and be in care for depression. I think this critical issue is important. If they have depression and if they're not in care, we do not actually think it's appropriate for them to engage in research. We need to help them get into care and then get into research. You have all these nodes. So good news is that you remember, I think, just to take a minute for this. Can you hear me?
Yes.
Yes.
Yeah. Remember, we have to take a minute for this. When we started, the goal, even though, and Dr. Wakefield always reminds me of this, we want to end depression. We want to have the best research ever. But when we started the 12 HRIs, not all of them, worked together. Not all of them had a research infrastructure. Not all of them had trained faculty and staff, all of that. That has been now accomplished. If anybody wants to come to us as the hub and say, we have this project we want to conduct across all 12 HRIs, all of them, I can promise you, will deliver. So that is actually the biggest accomplishment that people forget. That is not something I know anywhere in the country. So we have had quite a bit of success. We've now established this across all 12 academic medical centers. We've trained probably more than 155 research staff on all research procedures, measurements, assessments, IRB, safety, reporting to on any concerns, communicating with participants, going to community, etc., all of that. We've developed a very vibrant network registry that nobody else in the country has. And if somebody had actually questioned whether Framingham study should continue after the first 2 years, it would have stopped 78 years back. They have now continued for 80 years. So we can talk about it, but we have now the registry with significant number of patients. I think we have hosted many measurement-based care, collaborative care, training programs, etc. But the first two are accomplished in the first 2.5 years, guys. I can't really, it tickles me. The next two are our goals. So measurement-based care, collaborative care, we've trained, etc. Now, how well does somebody do measurement-based care is really reminiscent of that a famous person who said, it depends on the meaning of the word is, and our job in the next 2, 3, 4 years is going to be actually convert that depending on the word, we convince everybody that what it really means is what it means. That is, we do measurement-based care like they do in diabetes, like they do in asthma, like they do in rheumatoid arthritis, and that's the next task. We have completed over 7,000 research study visits. I'll show you some of the data. And our now job is to predict, and we have traditionally as a field, unfortunately, dealt with depression. If you look at any papers in depression treatment studies in the United States, including some of my most esteemed colleagues, Charlie, including you and me, right, we do 6, 8, 12-week trials. Most of these research evidence shows that depression is not a 12-week disease, and yet nobody does that. So now we have an opportunity to do this over the long term. This is what everybody is contributing. We have over 1,300 people who have consented. Don't get too lost in individual numbering, but I think we have a large sample that has led to over 7,000 research visits. Look at, these are not just clinical visits, these are research visits conducted by trained staff. Lot of time spent on data acquisition, entry, etc., and we can talk about it. One of the things that is most heartening and humbling is that most of the kids who are being enrolled have severe illness. This is not a mild, just a kind of a bad day or a bad week or a bad mother issue. This is real illness with significant severity of anxiety, depression, and suicide, and we'll talk more about it over the time. So we have a fair number of accomplishments already. The question has been raised about where do we go next. So I'm going to throw out a straw man. Don't kill me for it. We can modify it. We can do other things if there are smarter people who know better to do what needs to happen next. But I have a straw man, Dr. Wakefield, and I have sort of talked about this a little bit, and I want her to comment on it at the end, but this is what we would say we would do next. And that is really, we need to build this work going forward, publish the results. We have already 15 proposals in place. We have several publications we are working on. We really need to maintain this, so the existing network, so that the training, for example, all 12 of these HRIs very regularly lose coordinators, don't lose coordinators, sorry. Medical schools gain them. So there is a whole lot of our coordinators who go to medical schools and PhDs programs. So all this work, this discussion about CPWE, whatever, I can tell you, we are contributing to that. We have people who go to medical schools. We have people who go to graduate schools in psychology and social work. So that means we have to train new people. So that continuation, maintenance, data, et cetera, and I can talk to you. I don't want to bore you with all this. I think our next step is going to be to now having had this umbrella with 12 academic medical centers where all their patients coming in get approached for research is to convert this into a learning healthcare network. It's not enough to study what is happening to people when they get treated. It is actually even more important to actually learn from it and improve the care and then decide what works. And I think this learning healthcare network system part, I discussed last time, so I'm not going to again replicate what I said last time. And that is, if we don't learn, if all these network partners, they are champions, if they start putting these people through the research network, they also need to improve quality of care through measurement-based care, algorithms, collaborative care. That's the work that we need to do next. Have aligning stakeholders around a common goal. So it's not just enough to say, Susie, you have depression, and you enrolled in this. We have to then train all the providers that are in the network to improve the quality of care, because our outcomes in the real world are actually horrible. And I purposely stopped. We gotta improve our outcomes, otherwise we are not changing life. So there's expansion needed, refining current standards. I can go through all this, but creating an interactive forum where information, resources, should be seen not as one hub doing all this. This is really going to be a distributed network of expertise across the state. We'll also add new areas of focus. We want to encourage different places doing different approaches. Some people like Dr. Wakefield and Lubbock is now using, with full transparency, that is a software I developed, but Vital Signs 6, they have screened 6,000 people in 4 months. If anybody can find me a health system that has screened 6,000 people for depression in 4 months, I'll give up my work. I tell you, this is not easily done. So there are other places we'll do it differently. So those kinds of things we need to kind of populate. We also need to help with mental health provider training, and it is just not enough to kind of have people who get certification and licensure. We got to help them develop these better ways of treating, because otherwise there is, and let me stop again, only time I'll again stop for a moment of peace, and that is a lot of people around the country, around the world, including our medical systems, feel a little bit of what we do as hocus pocus. That needs to change by using this measurement-based care, more collaborative care, more objective ways of measurement. So that is what our little task hopefully is for the next couple of years. And I'm going to let Dr. Wakefield add anything if I missed anything, Sarah.
I just have a couple of points. One is that we know this is serious, and that's why we're here, and that's why we're getting funded to do this work. But I want to take home, how serious this is, that when a kid becomes 10, suicide becomes the second leading cause of death. I happen to have an 11-year-old and a 9-year-old. In 1 year, the most likely, or the second most likely reason that 2 of my kids will die is by suicide. I know what to do to prevent the car accidents, right? I put them in a car seat, but we still don't have really clear information about what we do to reduce suicide risk. We have some ideas, we have some research studies, we have some 12-week-long depression studies. But what I think we're doing here, in addition to the clinical work that is instrumental and really important, but what we're doing with this Youth Depression and Suicide Research Network and the Trauma Network is trying to understand if what we're doing or how we can do it better, and really inform these services and inform them more quickly than the decade it takes to get implementation from some of the research that we have. And the other thing I want to say is that it's not as hard as, the screening. And Dr. Trivedi, our numbers are actually over 9,000 now that we have screened. And what we are seeing from those screenings in the primary care clinics is in many clinics, more than 40%, more than 50% positive for depression screens. So just the number of what we're really talking about, how many people this is affecting in our state is it is imperative that we focus on this. And so we are. But I think, it's not, Dr. Trivedi said this isn't easy to screen all these people, but it did become easy when everybody said that this was what we needed to do, when the health system decided this is what we needed to do. So I appreciate being a part of this so that we can continue to advocate for this work and implementing screening and measurement-based care and following these kiddos and families over time, so we learn how to meet the needs of this crisis.
Okay. Any questions from anybody? Octavio, I see your hand.
Thanks, David. More of a comment, but great presentation. Definitely agree with the comments from Madhukar and Sarah. But Madhukar, you said something that triggered a thought for me, which is it'd be great for the research networks to also be seen as actually leadership pipelines, not only for young investigators, but as you pointed out, RAs and others that move into the field. If it's possible to capture that as well, even though it'll be a smaller data set, obviously, but the impact I think that it says in the message it gives to our legislators and policyholders, that it isn't, primary definitely is the impact of the research and its translation into clinical interventions and what it means for our populations and the lives that can be saved. But also, it is also a way to bring forth and include new leaders of tomorrow. So just want to make that comment. That's all.
I have to say, Octavio, you point out the most important thing. I know personally 8 to 10 people who left the network, which broke my heart because now I have to train new people, but left the network to pursue medical school, graduate medical psychology or graduate or social work. These are people who are going to now, without the CPB, going to become part of our workforce. So yeah, exactly. One final thing to and then I'll shut up, Dr. Lakey, and that is, I think I'm a little biased because I have developed this, but I think what Dr. Wakefield was talking about with this Vital Sign 6, it's not just a screening tool, Vital Sign 6, it's also provides ongoing measurements, decision support, and a dashboard for individual providers, individual clinics, et cetera, to monitor the quality of outcome for their patients so that in the long run, that actually elevates the outcomes for the whole population. This is like truly clinical intervention with a population health focus. So,
okay. Thank you very much, Dr. Trivedi. Any other comments? Hearing none, I think we need to move on, just kind of watching the clock here. So Dr. Nemiroff, why don't we go to you? Thank you, Dr. Trivedi.
I'm going to be a little merciful here and not subject you to another round of PowerPoints. And I'm going to be amazingly succinct in my comments to you. So the trauma network has done extraordinarily well. I want to give a shout out to Karen Wagner, the co-lead, and Jeff Newport, who's in charge of operations. We've actually evaluated just shy of 1,400 children, many of whom are in the immediate aftermath of trauma. And what's remarkable is that 66% of them have come back for their 1-year visit. That's the longest follow-up of any cohort exposed to trauma that's ever been studied. We have a very active publication committee led by Dr. Wagner. We have 6 publications that are in various stages of the process, and they will be certainly submitted in this coming year to really top-notch journals. And a couple of these findings are seminal findings in the field. The very first study ever to document inter-rater reliability in child psychiatry to the kinds of patients that we're seeing. This is a big deal. Carol Taminger has gotten the report back that we prepared for the entire research network back from the Psych Services Journal. And we have some revisions to make, but it will be accepted. in response to a query that David received from the legislature. We're in the process of now incorporating measurements of social media use and the type of social media being utilized by the children we're evaluating. And Dr. Newport can comment on this, but we should be able to start doing that in the next few weeks.
Very good.
We're also measuring, in terms of these children and adolescents, those who have been victims of violence and those who have been perpetrators of violence, because that's something that's obviously important for us to know. The pilot project funded by the Hogg Foundation, looking at 2 different evidence-based treatments for victims of sexual trauma, is just launched, with the first subject being admitted this week. And so what are we looking at in the future? We are determined in the future to continue doing what we're doing, because a lot of these children would never have come to the attention of mental health services. But we are absolutely dedicated to training all of the HRIs in evidence-based treatment for trauma. There is no current treatment component in the trauma network, but trauma-focused CBT is a extremely well-established and effective treatment for children exposed to trauma. We will train 2 psychologists at each HRI. This is a process in which they get certified, and then we will administer the treatment to the children we subsequently recruit, including delivering it by telemedicine. So this is really pioneering work. I want to thank Karen and Jeff for helping us put this together. We couldn't be more excited about this. We also will be applying for NIH grants to use to help augment the research support that we receive from the state of Texas. So I don't know if Karen or Jeff want to add to that description.
You're muted, Karen.
Can you hear me?
Yep.
Now we can.
To the research that would be going on, in which we'll be able to look at predictors of individuals that have had these treatments, see what works, what doesn't work, see what type of traumas respond to the trauma-focused therapy with that. And of course, we'll be comparing in-person to telehealth. All of those things are particularly important. So that's the research. But then what else do we have? We are training the workforce. So this is actual training of workforce at every single HRI. And that's sustainable, because once people are trained, they can train other people. So all of the HRIs will have trained clinicians available well beyond this research. And also we're proposing that we have some training in the community, at least on an annual basis, if we can. So it's a perfect combination, which I think is critically important, is that when we do research, from my perspective, it needs clinical application. And so now we're providing treatment and also expanding the workforce, and also seeing, can this treatment really be done via telehealth? No one's answered that question before. If it can, that opens the avenue of treatment for so many children who do not have to come in to see a clinician in person. Those
Very
are my
good.
comments.
All right, Dr. Trivedi, I see your hand.
I think Charlie and Karen, I am sure will agree with me, but I think one of the other things that we have mentioned before, but we need to, it always is helpful to repeat, and that is these 2 networks, we talk about them one after the other, but there is a whole lot of overlap. We have a lot of common measurements. We communicate on the regularly, and I think the resulting knowledge we are gaining is actually very complementary and very advancing the field, not only for one or the other, but for everything.
All right, very good. Any other comments? Seeing none, thank you again, Dr. Nimroff and Dr. Trivedi. Dr. Williams, it's time for our COSH update.
Okay.
Are you there?
Everybody. Is this the last thing on the agenda?
It is the second to the last.
Oh, okay. I was like, am I gonna draw it out really long so you guys have to stay till 3, or Should I speed up?
Please do not do that. That would not be well received.
I didn't think so. I'm joking. So it won't take us long. We actually don't have a whole lot to talk about today. It felt like we just met, like literally. So we're like, what's new that we can tell you? So Edith is pulling up the slides, I think, right now. I'm talking nervously till she gets done. So appreciate your tolerance for waiting. I'm sort of good at being patient, but not really.
Get it up. Give me one moment.
Yes, that was a moment, so I'm kidding. How's the weather now, Paso? Doing okay? Let's see a screen that start. Okay, great. So can we? Okay. Yeah, this is fine. So we're just going to talk CPAN, PeriPAN, and TChat. So go ahead and go to the next slide, and then the next slide. So we want to just give you the executive committee just a little amuse bouche. We are still working through a process related to the phones, and we've talked through a number of different options. But the CPAN leadership meeting, CPAN leadership is still having questions about it. So until we really have it completely ironed out, what we want to present, that's going to probably be delayed till next month. But we are working through a process. And I want to thank Dr. Everson specifically because his idea spurred us on to kind of consider just having a process that gets the phone answered and that there's not even a voicemail. But we'll be able to present that hopefully at the next meeting. When it comes to the ARPA initiatives for CPAN specifically, we do have the texting pilot has been completed. We did this over the course of the summer with all the HRIs participating with some what we call super users of CPAN to get their input about the texting process. We took that information from that pilot, presented it to the communications team here, and now we are working towards a goal of in October, we will have sort of a go live that all providers who've been enrolled in CPAN. So part of being able to use the texting option is you need to be enrolled in the CPAN network. But for those providers who are enrolled in CPAN network, we will provide communication and education around how to utilize the texting option to get a consult started. One of the things we want to be clear about is that the texting is not a back and forth with the provider about the situation. It's more of kind of getting in queue to have a call back or to have your nurse or your other staff member on the PCP's team to call to kind of move the consultation forward. So that option will be sort of statewide for all enrolled providers starting in the beginning of October. The second ARPA initiative is related to the direct consultation. We are in that process right now with 5 of the HRIs are piloting within their region, doing a direct consultation. So as a reminder, this process is when one of our team members, our physicians, our psychiatrist is speaking with the PCP, and there's a need that it looks like that would be better to help understand what's going on with the situation if our team saw that child and that family for a one-time consultation, either in person or via telehealth. And then after they have that visit, write up a report that's available both to the family and to the primary care physician, as well as a follow-up phone consultation to ensure that that primary care physician understands sort of the results of that evaluation and hopefully can then kind of move into a collaborative care model with our CPAN team to start providing services at the office versus sort of always just waiting for a referral that we know is slow in coming. So that direct consultation pilot we hope to have it sort of wrapped up by the end of October. And we're going to ask for those primary care physicians to participate to give us feedback, how that process work. The communications team has also created some FAQs, both for families and for PCPs, and we'll get feedback about are those communications clear and make sense, so that both the PCPs and the families are very clear about what is the process and the goals for a direct consultation. So we are hoping that this may be, after we get this information at the end of October, then we can start planning for that process of a rollout, in maybe the beginning of January, where we're allowing for this to kind of go, for lack of a better word, statewide. The final one is Safety A. I'm pleased to say that Dr. Cincinnati started officially at Baylor actually yesterday. I met with her today. She's very excited to get working on that project. She's reached out to the UT Southwestern team because they're going to work in collaboration with our team at Baylor to sort of do the infrastructure and the processes related to Safety A. For those who are not familiar and think, what is Safety A, Laurel? They actually had a name change from FISC to Safety A. This is a process of teaching a primary care team how to help manage a mental health emergency in their office, specifically suicidal or self-injurious behaviors. To Dr. Wakefield's point earlier about the sort of overwhelming epidemic we have related to youth depression, youth suicide, youth self-injurious behaviors. So this is what a lot of times pediatricians and family doctors don't learn in their residencies and fellowships is how to run a mental health code. They learn how to run other kinds of codes. If your heart stops beating, you're bleeding, or you're not breathing. But when somebody comes in their office and says they're suicidal, they often don't feel equipped about how to manage that. So Safety A is a very organized process in which to kind of involve the family and the young person and the physicians and their team on how to develop an appropriate safety plan that helps move them into their next sort of care environment as needed. So that project will hopefully get started and rolling, not enrolling, but rolling now that Dr. Pinsonati is here to help oversee that. And then for PeriPan, Dr. Wakefield has already presented. Our goal here with COSH is just continue to support that processes that included making the necessary changes to Lantana, including we do need to have a separate contract with Lantana because of how we need to manage the funds that are different from state versus federal. So we're going to have a separate contract for those ARPA funds that needed to happen for the additional lines from Lantana. We also needed to have a separate contract for the data management platform, trade as well, to make these things sort of stay clean with the different funding sources. And we're in process with that. And as Sarah said, the trade platform is available and up and running. We can enroll providers. It's also an integrated platform so that, again, as the Psychiatry Access Network potentially expands into other areas, we won't have to sort of rebuild again. So those are the things that COSH is doing to support PeriPan.
Dr. Williams, so sorry to interrupt, but I have to, and that is that Safety A is a wonderful example that doesn't happen outside of this kind of a consortium. I have a grant in to study Safety A for a particular underserved African-American girls, but in real practice, the collaboration that we have with Laurel and Dr. Williams and the CPAN network and the kind of immediate translation into real practice with the collaboration partnership is not common, not only not common, doesn't happen. So I think somehow figuring out how to convey the importance of this kind of a collaboration, Laurel, believe me, I have done this work for 30 years and yet I'm more excited about Safety than anything else because the kind of working with you and your team and CPAN directly to get this into practice right now rather than wait 30 years is really unique to this kind of a consortium. So sorry to interrupt, but I think it gets me excited because it doesn't happen, let me tell you, in the country.
We're excited for it to happen, and we're excited that your team can assist. And I agree. I think primary care physicians, and we all understand that the workforce expansion includes, that's what CPAN is really about, is it includes the primary care physicians. And until such time that ACGME and national bodies start to say that residencies need to look different for pediatricians and family physicians, that these types of programs are going to continue to be more than essential. Even after they change their mind and actually do it, it's still going to be essential.
I'm married to somebody who's a family physician, and she calls me every time and says, I have a kid who is suicidal. What should I do? And I tell her, call Dr. Nemiroff, because I can't do that, right? And so we got to train them to do it. And she's married to me, so I can't train her. But nevertheless, so
no, I
this
don't disagree. My dad is the same way. He's a family physician, and
this is so exciting. I'm telling you, I am tickled. So thank you for the partnership, Dr. Williams.
Perfectly. We're excited to be doing it. So again, like I said, PeriPan is launched. The teams are steadily working on their enrollment engagement, and we hope to have some additional updates related to that in the October meeting. The next slide, we're actually going to switch over to the dashboard for Lantana. So Edith has 2 maneuvers to do. She has to stop sharing her screen and then share it back again. And then we get to the dashboard. So we'll just kind of review some numbers quickly. And then we only have 3 slides after that. So in case you were wondering, oh my gosh, how much longer is Laura going to drone on? Not too much longer. So as you can see here, at the top line of our dashboard, hovering over the 8,923 providers have enrolled across the state. To date, this includes both physicians, nurse practitioners, physician assistants, as well as residents and fellows, over 1,700 clinics across the state. To date, we have, at the end of August, had 12,000 consultations with over 11,000 patients served. Again, sometimes they can have a consultation that's a generic question, not a specific patient. And our metric for returning their call within 30 minutes if they want is 90. Sorry, Edith, can you keep it up a little bit? Thank you. Is 90. And so we are well above that at 97.6%. And our median response time for a child psychiatrist to speak to a primary care physician in their busy practice is 5.9 minutes. So we are well underway with doing that. As you can see in the middle donut, Edith can show you that we have a nice variety of, go ahead to the 41.6, that is the number of pediatricians, clinic types that have enrolled, and then you can go down to the left and you can see the number of family physician clinics that are enrolled, and then the light blue are clinics that have integration of family and peds. So now it's going to move on to the middle section, Edith, just the very next section of the, no, not the graph of the page. Sorry, this is one. There you go, perfect, right there. So we want to point out to the left, the monthly consultation volume for the month of August hit our sort of second high for CPAN. So we're very excited about this. And the reason why I'm very excited about this is that summer is a lull time for mental health in children. It's no surprise that as children are not in school and potentially they're not feeling as stressed out and other reasons as well, you see sort of a less sort of work across the mental health field. But August is often also a little bit of a lull because kids are just getting back into school and people are just going to see their physicians for various things. So the fact that we're seeing such an early signal of elevation in call volume to me tells us that we're hopefully going to see this trajectory really continue to go up dramatically over the next several months. We do expect for this number to even increase further once we're able to have the texting option available to busy practitioners, as well as the direct consultation for those select patients whose families agree. And then when you see the clinic staff engagement, if she goes to that one, you can see that we have providers, 51% of our callers have called more than once. And so we do see this as a marker that teams and physicians are pleased with the service and they're calling us again. And finally, when you look over the clinic staff roles, the vast majority of time, it is a physician calling and asking for assistance. But as you can see, as she pulls away from that, looking at that particular part of the circle, we also have nurse practitioners calling, physician assistants, counselors, other team members on a PCP staff who might need to help get the consultation started, or if it's related to resources and referrals, actually just make the consultation happen and get the family and the children referrals and resources as needed. So we'll go ahead and move back to the slides. I did tell you I wasn't going to drone on for a long time. So we'll go back to the slides and we'll sort of talk T-chat and then we'll be done. So for T-chat, we wanted to let everybody know the school portal. So as TRAIT, the data management platform, was also building the PeriPan platform, they were at the same time simultaneously building out the school portal. So the school portal is now complete. This is allowing for us to have a standard system that the schools where we're inputting the referrals into for TRAIT. I'm sorry, for the state, not TRAIT. And within that process, we see sort of where we are in process with the school, but really more importantly, our school partners can see. And so they can see how many referrals they've made to T-chat. They can see how many of those referrals are in progress. And so we're going to actually have additional analytics that school personnel will be able to see and pay some attention to. We also have within the school portal the ability with the HIPAA compliant mechanism for us to share information back and forth with the document upload feature. So if they need to send us the IEP of the young person, or we need to send back 504 accommodations, for example, our recommendations to the school to help enhance and improve that young person's experience in school. This is allowing us to do that sort of process seamlessly and helping the school personnel not have to go to 20 different places to do the process. The other piece that we'll be doing within the data management system is we will have at the session level for a TChat that we will be able to track which of the sessions that we're doing across the state may be related to one of the ARPA funded projects. That change to the session level documentation should be occurring by the end of September. So we'll be able to track the ARPA funded programs and projects. Again, we don't have a lot of data to share because it is the beginning of the school year, but as you can see here, even though school literally just started some places just a week or two ago, we've already gotten over 600 referrals to the TChat services across the state. This is a substantial increase from last year, and of those 600, over 600 referrals, almost half of them have been enrolled. Remember, sometimes we can get, a couple hundred referrals like the last week of a month, and so it takes, another week or so for those patients who've been referred to actually get the families to kind of consent and agree to care. So there's always a bit of a lag between we get a referral and when a young person is enrolled. And then even though summer is often lighter for school for children's mental health, I do wanted to point out that despite that, all of our teams continue to see young people over the summer, and we had plans for some campuses remain open so that we were able to see kids on campus. Other of the appointments occurred in the family's home with a legal guardian present. But even still, in the month of August, we had over 6,600 sessions recorded for TChat services in that month. So that, I think, concludes the presentation. See, I told you speed.
Very good. Are there any questions for Dr. Williams? I don't see any hands, Laurel. So again, thank you very much. Again, it's the beginning of the school year and those numbers are going up, and look forward to seeing the continued progress. That's great. Anything on, I don't think Steve Pliska's here, so I don't think we have an update on CPWE from anybody. Data Management Governance Committee, Dr. Vo, anything from you?
No updates on that.
Okay. All right. Well, we're going to have an update now as our final part of this conversation, some of the great work that's going on in El Paso. Dr. Martin, you want to tell us about the work that you're doing and to increase enrollment in CPAN and TChat? Dr. Martin?
Yes, thank you. Yes, thank you. Push the wrong button. Okay. Let's see. I did prepare a very short PowerPoint. All right, can you all see it?
Yep, that's good.
Okay, are you seeing this, the note side and the other side, or just the
We just see the slide.
Awesome. Okay. So we're talking specifically here on face-to-face outreach. Of course, there's a lot of other types. So we have learned a lot during our face-to-face outreach. And we've taken a lot of photos. So most of the photos, I think all the photos you see in here, one of us on our CPAN team took. We have learned a lot about the people, the lifestyle, and the land. And there are so many different, it just even within our region, just so many differences. And it's been really great to really dig in and meet a lot of people and really understand how people's lives are. Things that I would never have guessed in a million years. So in the beginning, just like everyone else, we were a bunch of doctors, counselors, medical school staff that didn't really know how to do outreach. And we were, wondering why doesn't everyone just want to join us? It's free, it's fabulous. Why didn't you want to join? But we were still having a slow start. Then of course, the pandemic, one of the big problems we had especially during the pandemic, was that nobody wanted walk-ins. And phone calls at front desks are very, very well trained to keep out the riffraff and the CPAN and TChat people. And there were too many emails, so we decided we didn't have enough progress. So we had a planning retreat with our whole CPAN team, and then TChat also had planning sessions, and we combined somewhat. And so we decided we were going to work on these things here. And this is a photo on the highway from El Paso to Van Horn. We planned ahead for the whole year. So we saved time in every month for either 2 or 3 consecutive days to go out, drive around, meet people, either people that are already enrolled or people that we need to enroll, both for TChat and CPAN. And then we also have dates for local travel just around our own county. Part of the time we're looking, I already said that, enrolled, not enrolled. And we do TChat and CPAN stuff together. So the CPAN, this is mostly the CPAN team. We have this van. This is another grant. We have a few other grants that we're teamed up with our state funding. And this is one, our university has this care van. And so we drive this around. And then you can also see my shirt. We have these shirts. So we just started trying to get appointments, but we really, as long as you have a couple appointments in each place that you go to, usually people will talk to you. The shirts help a lot. People all over every town that we've gone to, they come up to us and they're like, oh, Texas Tech, that's where I went. Of course, most of them did not go to our Texas Tech, but that's okay. We just smile and say, yeah, what's going on in your town? So for each town we go to, we try to make appointments, but we don't worry if we only have a couple, because what we find is if you have a good response from one clinic or one school, then you can get contacts at the ones next door or in the next county, and then they'll call over there and then they'll let you come in. Another thing about making appointments and dropping in, it's hard to get appointments with schools somewhat at some schools, but the 3rd week in June, summer school is still in. So the staff are all there, all the people like the counselors, the superintendents, assistant superintendents, vice principals, those sorts of things. So you can talk to those sorts of people. So they have time to talk to you because summer school has many fewer kids than, of course, a regular school year. And so we were able to get a lot of time to really explain the program when we went out in the 3rd week of June. So I'd really recommend that, but it depends on what your area's school year is like. We assign a role to each person. Adrienne Harrell, this is in the red sweater. She's our program manager. She helped me with all these slides. She helps a lot with outreach because she is the only one on the team that had ever done outreach before. And her job is to interview all the locals. She finds out so much everywhere we go, whether it's the gas station or the coffee shop or the schools and clinics. So just having conversation, the more you can get people to talk to you, the more they remember you, and hopefully the more they feel comfortable calling and also signing up with you if it's TChat. Sarah, that's me. This is just a joke, but I think people do like it if the doctor goes too. And I think it's really hard for doctors they feel like they need to stay and see patients all the time. But I think that going out myself has made somewhat of a difference. And they usually do not turn you away if you have a doctor with you, even if you show up out of the blue and you have never heard of them and they've never heard of you. They usually will let you in. So if anyone is having trouble, I just send your doctor, it's getting into a certain practice, I just send your doctor over there in person. And a lot of times they will let you in. And Bethany, make sure we behave ourselves. Yes, Dr. Trody?
It may just be you, Dr. Martin.
Maybe. I have my Texas Tech shirt on and all, you know. Let's see. And we always give out stuff. I think all the teams are doing this. But for TChat, I think the most important item is we bring samples of all the papers that you have to fill in because it's very confusing. Our university, you have to do the tax form, even though it's a no-fee service, which I don't quite understand. And you have to do a vendor form, but it's just part of the process. So when we have them there, then they're expecting that and they know what they need to do to join, even though maybe it doesn't totally make sense. It's just what you got to do. And they all understand that every place has their own bureaucracy because they have theirs too. For our CPAM folders, I think the most important one and most well-liked one is these little card here. It is a cheat sheet on medications, and it is the size so that it can clip onto your hospital badge, your clinic badge. And people really like it. I don't know how much they use them, but they really, really like it. It's almost like a little transitional object when you're first starting out in psychiatry. And so people love these. This was actually not my idea though. This was Dr. Pliska had a project years ago that one of my pediatricians here at Texas Tech, she's not my pediatrician, but you know what I mean, in my network, in our CPEN network, she had been on a project with Dr. Pliska where it was a pamphlet about prescribing psychiatric meds for depression, anxiety, and ADHD. And so we just made it into a card size because she said that that would be helpful. She could always have it with her. So we have first line for depression, anxiety, and then first and second line treatments for ADHD. And then we have always bring a map that says exactly which we're covering. But then we also talk about this is anywhere in Texas. Tell your friends, even they're not in our region. This is a picture of the trips, the last most recent 3 trips we took this summer. The blue one was a killer. If you drive straight from El Paso to Eagle Pass, that's about 8 hours, but you put this loop here in the middle, it's probably more like 12. So we stayed down here in Terlingua right before Terlingua one night. This is a Big Bend area, and if anyone has not been there, you'd have to go. It is absolutely gorgeous. I think the most beautiful place in Texas. I don't miss it. And then we just stop in every single town, every single school district that we can find. Follow-up phase. Oh, this photo here. This is us. Google said there was a school district right here, and there was not. So every once in a while that happens, but you know, we just got back in and found out where it really was. They're almost always in the very center of town. So I was kind of suspicious that this was not going to be one, and it was not. So Google is not always right. So when we get back, the first thing we do is all the people who said, oh yeah, that sounds like a great program, we go ahead and schedule them for the initial trainings. And I think that works really well because you have the person you've met with, even if it's not the superintendent, probably has the authority to schedule some trainings. You want to get somebody at least that high up. And then once they've had the initial training, they feel like they're part of it and everything keeps moving forward. So I think that's been really helpful. Just as soon as anyone expresses any interest at all, go ahead. And then schedule follow-up meetings for those not as interested, trying to get them interested. We've had a couple school districts that have not shown much interest, but every once in a while they meet with us. And so some of them we eventually have gotten to join. So I think, and then somebody had talked earlier in the meeting about turnover. As soon as somebody turns over, you got to get back in there and try again. And a lot of times the next person will say yes. And then for CPAN, we add them to trait. And then we have these 2 different listservs to make sure we get everybody. CME, our CME one, we send out to everyone. And then Project Echo, of course, is just our people that are providers. And then, so we went from not knowing anything to, we got all this stuff done. So after this summer, before the summer, we had 15 active MOUs for TChat. We got 12 new ones that are in process. 9 new that they're filling out the paperwork and they want to follow. They wanted to sign up. One school is, we already provide services through a different grant. And there's one district that just is not interested. So this is us going all over all these places. If anyone's never been to this Prada installation of art, I don't know what it is, but it's pretty funny. But these are just these schools are amazing. These rural schools are so old and they have really put a lot of time and effort into maintaining them. And so they're still using buildings that are 100 years old. And with that goes along all the gorgeous buildings, floors, all of that. So, and then in terms of TChat, we enrolled 18 new clinics, 50 new providers, and then a lot more consults. We're still the smallest region here in the consortium in terms of the amount of children we have in our region. So yes, our numbers are not huge, but they are going the right direction at least. So we've had a great time. We've learned so much. Here's Martin Field, my field. No, this is some coach years ago. They named the field after him. This right here is a barbecue place somewhere in our region. I can't even remember what town. I think Wink, Texas, or Kermit, Texas, one of those. So we've had a great time. We've really gotten to know people and everything is looking up. So we're going to keep on doing it. Now I have to stop sharing.
Amazing fun, Sarah. Sounds like amazing fun. Seriously.
It's been fun. We've met so many people. And life is so different. For example, one school, they didn't have enough for a football team. It's Del City district. They have one school for all grades. The high school didn't have enough kids for the football team, so they actively recruited all the girls. So all of the kids in the high school, unless maybe like one or two didn't want to do it, but pretty much all the kids in the high school are on the football team, boys and girls. And it's awesome. And, that was that was just a great trip. That was a great trip. Now, we have also found out things that aren't so great, like that TChat is helping with though. Let's say you don't have any papers. You cannot drive around this area of Texas because there's Border Patrol checkpoints everywhere. And so these kids really have nothing, no access to anything. And so telehealth is their only option. And in conjunction with TChat, we also have a program called Rural Telepsych for Youth that is privately funded. And so we can see all types of kids. One type of kid, I'll put a plug in for one of my favorite age groups, transitional age. They're cut off of Medicaid already. They have no insurance. They're not old enough to have a job yet. Dr. Trivedi's nodding his head because a lot of those kids are in those studies. They cannot afford to pay for their care. So it seems kind of unfair because like my kid, she's going to be on my insurance until she's 26. But she'd probably have a job before that, more likely to. A child whose parents, or young adult now, whose parents can't afford it or is in the Medicaid range for salary income, they get cut off at 19. And so this other program we kind of filling in a lot of the other gaps that they're already graduated from school, so they can't do TChat. So we've really, really enjoyed that. And so one of my other favorite programs. So we've taken a couple of little grants and added them to the great stuff that TChat is doing for the state. Anyway, that's all. Thanks guys for listening.
That was awesome, Sarah. Again, not only the presentation, but the work getting out there in the community, letting people know who you are and working it to build that referral capacity. That's really great work. So congratulations on doing that and look forward to seeing how it pans out with the increasing numbers of schools and clinics that'll be, because of that personal touch, feel comfortable with working with you. So congratulations.
Thanks. And now we just need more employees.
Yeah.
Just like everybody, though. I was so happy when I heard the presentation about workforce expansion starting at even the community college level. That's amazing because get them when they're young, when they're all excited about mental health, and catch them at that first moment. They're thinking about what the rest of their life is going to be, and they'll have a great career. And the children in Texas will have such more service. So I love that.
All right. Well, we've completed the agenda. Is there anything else germane to the agenda that we need to talk about before we close this meeting? Hearing none, I want to thank you everyone for spending your day with us and appreciate the conversation. And we'll again have ongoing conversations with many of our institutions as we refine the budget and work out some of those things that we talked about today. Would again encourage people to take a look at that workforce document. And if you have input, edits, please send it to us within a week so we can move that forward and continue to push that conversation And we look forward